Without these two gentlemen and Kathy Black, this conference would not be happening. So let's give them a big round of applause for organizing it. Jesse McCarran is a local guy, grew up here in Portland, Oregon, and went off to college back east somewhere at Williams, and then did his medical school training at Vanderbilt, was it?
No,
Penn. And then residency at Vanderbilt. Where is Vanderbilt popping up? I got you. Gotcha. Okay.
Vanderbilt, I'm sure. Yeah, residency.
Dr. Shano did. GW, residency at GW. Came back here to Portland, where he was at the Veterans Administration Hospital for 10 years or so. Is it not right? 9?
10 years, but it was only 6.
6 years, okay. I know him well. And then he joined us at Rebound not too long ago. Jesse still holds an appointment at OHSU doing academic work and teaching. And focuses on reconstructive shoulder surgery. Next to me is Dr. Brian Regal, who many of you know as well. Brian has really helped to organize this conference, and I would say that for the last 3 years, this conference has really been the brainchild of Dr. Regal. Dr. Regal is also a local boy. He went to Benson Polytechnic High School, one of their fine graduates there, then off to become an Oregon State Beaver. Then OHSU for medical school. Briefly thought he might want to be an orthopedic surgeon. Boo. And then got his mind straight off and ended up doing neurosurgery. Went off to the University of Utah for a while. Then Brian served in the United States Air Force, was working in Afghanistan, taking care of our soldiers there, as well as the local people afflicted in the war there. We were lucky enough in Portland to have him come back here to the community. He worked with me at OHSU for a number of years, and then was in Missouri for a brief time, but couldn't get back to Oregon fast enough and to Southwest Washington fast enough, and joined us at Rebound several years ago. Jesse McCarran and Brian Regal are going to talk to us today about that age-old dilemma: is it the neck or is it the shoulder? Gentlemen.
All right, so we're just going to pass this mic back and forth. I think that'll be easier. We struggle with the same thing you guys do. Almost 100% of my patients with shoulder problems who show up in my clinic are also complaining, at least to some degree, of involvement of the neck. As we all know, oftentimes some of this neck pathology will radiate down into the arm. And it can be hard to sort out what the primary cause is, or if there are actually two separate things both coexisting at the same time and feeding into each other. And it's really common in our practice to have to trade patients back and forth. And I can actually say, since coming to Rebound, where I'm in a practice where I now have neurosurgeons that are in the same practice with me, this has made my life much easier and much more enjoyable, because it is so much easier to share and collaborate amongst people who are really still part of the same team, because there are a lot of people that I do need to send to our back specialist, either our neurosurgeons or our physiatrists, to figure out how much of this is really the neck that's causing things and how much of this is something in the shoulder that I should be fixing. This is the last talk of the day. After we're done here, we'll all go over across the pavilion right here to our Rebound clinics, where we'll go over physical exam and pearls and tips for joint injections. So we hope that you'll all join us here. This has been a lot of fun. This is the third year we've put this on. We've really enjoyed it every year. We really appreciate the fact that all of you are willing to come and spend your Saturday hanging out with us. And we hope that this has been valuable enough for you guys that you'll consider coming again next year, because we'll be certainly putting it on next year, and we hope we'll be seeing you here. So the talk we're going to give is actually one single patient whose story spreads over several years. So that will come through as the main sort of underlying line through this talk. I'm going to pass this off to Brian so he can start the story, and we'll get this going.
It is nice to share the pain of patients with other people, as you all know. But differentiating between a cervical spine and shoulder can be confusing. In general, I think Jesse and I would agree, if you palpate the shoulder and it hurts, it's probably the shoulder. If it goes all the way to the hand, it's probably the neck. So pinched nerve in the neck will oftentimes go all the way to the hand. If you palpate their shoulder, anterior, posterior capsule, it oftentimes will hurt, and that's probably the shoulder. The big confusion is our aging population is they oftentimes have a little bit of both. Their shoulders, their joints, they'll all be painful everywhere you touch. And so this particular patient was one of those cases where it was not clear up front. But differentiating between shoulder and pathology, specifically a C5, pinched nerve in the neck, can be very confusing. And we're all wired about the same in terms of a dermatologic pattern for a pinched nerve in the neck will follow a very similar pattern for all of us, but we can be off by about 1. So a C6 nerve root pattern to me, which will come down the arm and go to the thumb, might only go to the shoulder in some people. But there's 7 bones in the cervical spine. They're numbered 1 through 7. And what the difference is that there's 8 nerve roots, though. And so the first nerve root comes out between the base of the skull and that arch of C1. And so that's where the numbering gets a little confusing, because in the cervical spine, the nerve root that exits the foramina is above the vertebral body. So for example, the C5 nerve root will exit above the C5 vertebral body, unlike the thoracic and lumbar spine, because then there's not a C7, but there's a C8, and then below that it goes T1. So that's where things get a little bit more straightforward. So an L5 nerve root will come out underneath the L5 pedicle. But in terms of the cervical spine, the C5 and C6 nerve roots, which is specific for differentiating between a pinched nerve in the neck and shoulder, will come out between the C4-5 and C5-6 foramina. And as we get older, we all get a little rusty. So what only makes sense for Jesse and I and others in surgery is we have to match up with what's rusty, with what's squeaking. So if it's a left-sided squeak, I got to look on the left side and fix something on the left. Unfortunately, when we get these reports back, everything looks rusty to us on X-ray, which is depicted here. Unlike the previous X-ray, now we have some bone spurning, some osteophyte formation. And so over the years, as we age, our joints look a little rusty. So I oftentimes, the first thing I mention to patients when they come in with the report is, we all have birthdays. Because of that, we all get older and we get a little rusty. And then I say, your X-ray looks age appropriate, and then I try to frame it in terms of where they're at with their age. Age appropriate, younger than steady age, and then maybe a little bit more than stated age. But these are the typical patterns that we'll find, and specifically for the shoulder, the C4, C5, and C6 can get a little confusing. But in general, if the pain radiates down and gets into the thumb or gets into the hand, that's going to be a pinched nerve in the neck most often than not, and not necessarily the shoulder. And I like this particular paper because it went over the nerve roots and the dermatomes and as well. But the one that we're talking about today is the C5 nerve. But it'll get the pain, the myotome, it'll get into the pec and the supraspinatus. This is all shoulder region pain, discomfort. And oftentimes patients won't come in and tell you exactly where. Very hard to verbalize pain for a lot of people. But one thing that I found very consistent, if you ask them just to point to it, ask them to draw a pattern with their hand, they're very good at drawing myotomes. They're very good at drawing dermatomes. So if they draw it down their hand and they get into their thumb, it's more often than not going to be a C5-6 problem. So I'll focus in when I look at the MRIs and the imaging modalities in terms of trying to help focus my exam. Because the reality is we all have to see more patients every day than less. So my time over the years with patients has just done nothing but diminish. Before, when I first started, we had maybe 45 minutes to see a new patient. Now it's down to about 20 to 30. So I really have to focus things pretty quickly in terms of guiding which way we're going to go pretty quickly. And I found if I just ask them to point to it, just ask them to draw it, it seems to key things in a little bit quicker. So the rotator cuff you see here, and this gets into, if you palpate the shoulder, it oftentimes is the shoulder. But this is a 41-year-old male, about 4 weeks of low neck pain. I differentiate between high, mid, and low neck pain just to kind of help my mind key back in when I see him next. I can't tell you that clinically that makes a big difference to me overall, but I tend to say low neck pain when it tends to localize to the kind of the T1 spinous process and maybe the C7 spinous process, and then out into the upper trapezius. So when I see that and I read that with my own dictations, that's what I mean by that. And then writing it into the right scapula and shoulder, and then all the red flags we ask, motor weakness, imbalance, bowel and bladder, were all negative. And then had really, to this date, had tried everything. And when the patients come to us, this is what we recommend. We recommend that they're willing to try chiropractor, go for it. It turns out that if you look at Consumer Reports, if you look at the annuals of the internal medicine, this is what patients love and do, and what helps them get better. So I always ask if they're doing any of this stuff, and I encourage them to do so if they have not, because it beats a knife. But full strength, mild tenderness in the anterior shoulder capsule, and then the X-ray showed just mild to moderate degenerative changes. 1, 2, 3. We would expect that nerve to exit to get into to be the C4, C5 nerve. 2, 3, 4, 5, 6. You can see at 5, 6 there's a little bit of bone spurring here compared to the other levels, a little bit of loss of disc height, and this does bear out on the sagittal T2 weighted MRI, C2, C3, C4, C5, C6, a bit of a degenerative disc there, and then the spinal cord, you lose a little bit of the anterior aspect of the cerebral spinal fluid. It doesn't mean a ton unless there's a raging redic, so I can't necessarily recommend surgery at this point, just because he's not complaining of symptoms that go all the way to the hand. And then based upon the exam with some minimal tenderness in the shoulder capsule, I always recommend maybe starting with at least looking into having their shoulder looked at. But these are the initial non-surgical mechanisms. And in this particular case, we were really unclear if it was shoulder versus a C6 redic or C5 redic. Patient wanted to try acupuncture and an epidural steroid injection, which we encouraged. We offered a referral to one of our shoulder specialists at that time, and he declined at that time. So this is where Jesse gets involved.
Thanks, Brian. So just a little refresher on shoulder anatomy. We're looking at the bony structure of the shoulder here in the upper right corner. You've got the scapula, the clavicle, and the humerus, which make up the shoulder complex. The scapula here is seen end-on from the lateral side. This pear shape here is the glenoid socket with the surrounding labrum. And then external to that, you have the joint capsule. The shoulder architecture from a bony standpoint is a lot like a golf ball on a golf tee. It's a very large humeral head on a very small, very shallow socket. And that affords the shoulder 6 degrees of freedom, and the shoulder actually has more range of motion than any other joint in the body. But those advantages to the architecture also come at a price. That means the inherent bony architecture of the shoulder is unstable. And that means that it's the soft tissue envelope around the shoulder and not the bony architecture that confers stability and function to the shoulder. And this becomes very important because this is where we get all of our issues with our rotator cuff symptoms and a lot of the pain that we get in the shoulder with activities of daily living, as well as with repetitive wear and tear and aging. So from a biomechanics standpoint, the more superficial muscles that we can all really easily identify, the deltoid, the pectoralis, latissimus dorsi, and teres major on the back, these are all the large muscle groups that actually affect that ability to put the arm through a large range of motion. You know, when you raise your arm over your head or when you push or pull a heavy object, you're primarily relying on these larger rotator cuff muscles. But the problem is that those muscles acting in isolation will not allow the shoulder to work properly because of that inherent bony instability of the shoulder joint. So that's where the rotator cuff comes in. Those 4 rotator cuff muscles, subscapular, supraspinatus, infraspinatus, teres minor, surround the ball and socket joint and provide dynamic stability to the joint. They keep the humeral head centered on the socket while all of these larger surrounding muscle groups push and pull to rotate or bring your arm to a range of motion. And they create this fixed fulcrum, which is so key to allowing that shoulder to pivot and rotate. For the most part, and to obviously oversimplify, the majority of the shoulder pain that we see is, especially in patients over the age of 40, either going to be related to the rotator cuff and that surrounding envelope. It's going to be related to arthritis, just wearing out of the actual cartilage surfaces, or a combination of the two, which we often refer to as rotator cuff tear arthropathy, where someone has both worn out the rotator cuff and has lost the cartilage in the joint. So rotator cuff pathology is extremely prevalent in our population. It accounts for over 600,000 surgeries a year, actually, as of this year. It's almost 50% of all people over the age of 60 are going to at some point develop rotator cuff symptoms. Shoulder pain is one of the most common reasons, as you guys are all aware, that your patients present to your office with musculoskeletal complaints. In young patients, rotator cuff injuries are much less common, but when they do occur, they're almost always traumatic. In the aging population, it's much more likely to be degenerative in nature. We recognize more and more as we understand the natural history better that much like arthritis, rotator cuff pathology develops over time simply as the result of the normal aging process. And so most rotator cuff pathology and most rotator cuff pain we see is not related to one specific traumatic event, but rather just overuse of the shoulder and wearing away of those tendons over time. So the problem with rotator cuff symptoms and the confusion with neck versus shoulder etiology is that most of the symptoms that your patient's going to present to in your office with shoulder pain are almost identical, whether it's coming from the neck or the shoulder. Rotator cuff pain often presents as pain localizing to the lateral deltoid. It often involves the periscapular muscles because those periscapular muscles are splinting or making accommodations to try and compensate for the non-functional rotator cuff, and it causes pain at night. These are all characteristics of the pain that we see with radiating symptoms from the neck as well. As Brian already alluded to, tenderness to palpation at the shoulder is a good way to help sort this out, right? It makes sense if you poke the shoulder and it hurts, then there's some degree of pathology that is intrinsic to the shoulder. However, even that can sometimes not be as straightforward as you would like, because as Brian pointed out, the C5 nerve root innervates some of the rotator cuff muscles. So if you have weakness in the C5 nerve root distribution because the nerve is getting pinched, you're going to have weakness in your rotator cuff. That will lead to subacromial impingement, and that will cause pain at the shoulder. And it's not that you don't have true intrinsic shoulder pain, but if you fix the C5 radiculopathy and the weakness related to C5, the impingement symptoms would spontaneously disappear. So you can't always sort them out. And it's usually not an either or, but there may be one of the two sources which is the predominant or the most influential source. And we're often trying to figure out, okay, we know both are going on, but is it shoulder first and then neck, or is it neck first and then shoulder? So for these people, when they present with pain and they have had a significant trauma or have a profound functional deficit, we're pretty quick to jump to advanced imaging. Most often, this is an MRI, although we can use CT arthrograms. This is a poorly showing up picture of someone with a rotator cuff tear that was traumatic from a dislocation. As I mentioned, you can use arthrograms to evaluate the rotator cuff in someone who can't get an MRI, and we have ultrasound techniques too. In the absence of a significant trauma or a functional deficit, I don't usually jump to advanced imaging. We get an X-ray to make sure there's nothing obvious on X-ray, and the MRI or the advanced imaging can wait until later if they're failing conservative treatment measures like at least 6 weeks of physical therapy, rest, activity modification, use of non-steroidal anti-inflammatories. So this story picks up several years later. Same male, he initially declined referral to a shoulder specialist. However, the shoulder pain did get worse and progress, and so he eventually decided that he did want to come see someone about the shoulder specifically. He was reporting intermittent right shoulder pain. It used to be only with heavier activities, but now it's getting to the point where it's pain during the day and trying to sleep at night. He's using trazodone to try and sleep at night, but it's still waking him up several times at night. He localizes the pain to the anterolateral deltoid, wrapping around to the posterior deltoid, which is certainly a classic presentation for rotator cuff symptoms. He's tried 2 subacromial steroid injections, and they've been frustratingly inconclusive. They did help. So that suggests if you stab someone in the shoulder with a needle and you put medicine in the shoulder and the pain goes away, well, you think it's a shoulder problem. But it didn't help for as long as it should have. It only helped for about 2 days. So you don't really know if that is corroborating or sort of arguing against this being an intrinsic shoulder problem. On physical exam, he's tender in the rhomboids and the infraspinatus, so all those periscapular muscles that we talked about. Again, that could be neck, it could be splinting from the shoulder pain. He has full active range of motion and 5 out of 5 symmetric strength, left and right sides, and he has positive impingement signs. You put his arm all the way up over his head. He has a positive near sign, which means his rotator cuff is tender. There seems to be some degree of real intrinsic shoulder problems here. And at this time, he has a normal distal neurologic exam. I failed to do a cervical spine exam on him. I usually do when I'm suspicious about both people, but when I'm suspicious about a potential neck contributing factor. But I was surprised when I went back and reviewed his chart again that on my first evaluation of him, I did not check his cervical spine range of motion, and I should have. His x-rays were normal to me. I don't see any arthritis. I don't see any narrowing of the subacromial space or any fractures. So he had pain only, no trauma, no functional deficits. So this is definitely not something where I would jump to non-operative treatment. This is not something where I would jump to advanced imaging. I would start with non-operative treatment. We already got the x-rays. We asked him to rest and avoid specifically the provocative activities, and we put him through shoulder-specific 6 weeks of physical therapy. He's already had 2 steroid injections. I don't want to give him a third, but in general, you would talk about trying a subacromial steroid injection plus or minus the use of NSAIDs. So he comes back 8 weeks later. He's still got So he had these rotator cuff symptoms. We recommended physical therapy. We asked him to do this and return in about 8 weeks. I typically tell people you have to invest at least 6 weeks in physical therapy when it comes to rotator cuff or shoulder issues before you know if it's going to work. There are times when people will try it for 2 or 3 weeks and then they'll quit and come to me or come back to me. And I almost always have to get them back in so that they've completed a 6-week course. The first couple weeks of rehab for rotator cuff and shoulder issues is usually not going to be pleasant. And it takes a couple weeks to turn the corner. So you really should have these people invest at least 6 weeks before you can have anyone render an opinion as to whether or not it's working or not. So we sent him for 6 weeks of physical therapy, told him to return in 2 months. Unfortunately, when he returns in 2 months, he does not feel like the physical therapy has improved him. His range of motion is actually worse than at first evaluation, so he's losing function. At this point, he has failed our initial attempts at physical therapy and function is decreasing, so I did order MRIs, but not just of the shoulder, I ordered one of the C-spine as well. The MRI of the shoulder does show some mild multifocal cuff tendinosis, but no rotator cuff tear. It does show a lateral acromion, which is downsloping and abuts the supraspinatus, so you could argue that those things potentially suggest some intrinsic cuff issues. But really, if you compare them side by side, the descriptions for the cervical spine are much more pronounced than what we're seeing in the shoulder, and especially the C5 and through 7 canal stenosis with cord deformity at the C6-7 level was suspicious for me that this was probably why his shoulder wasn't getting better. So at this point, I hand him back off to neurosurgery, and Brian takes over again.
So we're now, interestingly, we're about 5 years out from initial, but about 2 years out from where we initially started with seeing us. He's now 42. And this is not uncommon for people to kind of come back and continue to see us for a while. And really what I try to do is I try to drag my feet, make them sure they've really failed everything before we start putting incisions on them, especially with the cervical spine and low back. When we start talking about fusion, it does sometimes set us up for more problems in the future. Those problems run about 10 to 20% of people will need another surgery on their spine within a decade after you've operated once. Some people will argue it's because the degenerative processes at other levels continue. Makes some sense. That's definitely true. But the other thing that's true is we definitely change the biomechanics of things once we've operated. And so I think it's a combination of both. But at this point, intermittent numbness in the biceps in the lateral forearm and to the thumb. So now it's maybe starting to make a little more sense in terms of a nerve root impingement syndrome in the cervical spine. Continues to deny motor weakness, balance, bladder, and as you recall, has really tried everything to date. On exam, subtle weakness in the right bicep, and then continued mild tenderness of the anterior shoulder capsule. And we repeated his imaging. And so X-ray, lateral view, C2, 3, 4, 5, and 6. You can see now the spine. So this is posterior. You can see now that he has a little bit more of a, if you remember that previous imaging, a little bit more of a disc osteophyte complex or a bone spur, which you can see a little more clearly now on the new MRI. So 2, 3, 4, 5, 6. And it just appears like he's grown a little bit more of some bone spurring. So the current scan is on your left. The previous scan is on your right. And so over the years, he's just continually to slowly have grown this osteophyte, this bone spur, which has slowly started to compress the nerve that exits at this level, which is the C6 nerve, which makes sense now for some of the numbness going into his thumb. We recommended, it's nice to recommend an epidural steroid injection. Why these work long-term in the face of arthritis, I have no idea. But sometimes you get lucky with a hip, with a knee, with a cervical impingement syndrome. You inject somebody once, it's all they need, and they're off for the rest of their life. And I can't tell you who that is up front, but I always encourage patients to at least try it once. Usually it works for about 3 months, and then if it is, in fact, a pinched nerve, that will slowly come back. But every now and then you'll get somebody that just gets enough relief. I think it has to do with just buying them enough inflammation. And then I don't know if they just continue to get a little arthritic and they auto-fuse their spine in some position where they're no longer moving and that nerve just isn't irritated anymore, or if the nerve at some point just stops caring that it's pinched. In a way, it doesn't matter. They've dodged a surgery, so I always encourage people to at least try an epidural steroid. The way that's done, though, it's done with a little bit of conscious sedation, so it is a little bit of a rigmarole. It's not something you can do in the office or I can do in the office. I'll refer them to somebody that does that locally. What they do is they start an IV, and it's kind of a little bit like having a colonoscopy. They'll do a little propofol with anesthesiology, make them comfortable, and then under X-ray visualization, insert a nerve into the foramina. They'll do a little bit of a dye study to ensure that the we're not into nerve, that they're outside of the nerve capsule, and then they'll slowly infuse a combination of a local anesthetic and a steroid into that. The local anesthetic takes place right away, so when people come back to clinic, they'll oftentimes say it didn't work at all, and I'll say, well, did you feel better at least if you walked out of the office? And if they say yes to that, then I consider that a pretty good diagnostic study and that they were kind of on the right track in terms of at least figuring out where their pain generator was. So in this particular, they got a brief relief, and then it becomes to, is there a surgery that we have to offer to unpinch the nerve? The surgical indications is life-limiting pain, which this patient didn't particularly have. Pain greater than 2 months, which they definitely had. They've been kind of ongoing now, slowly getting worse. And then or progressive motor deficit. And in this particular case, we didn't really notice any bicep weakness before, which we were noticing now. We have a choice in which way we do the surgery. So this is the sagittal MRI T2 weighted image. This is the front part of the throat. And so it goes skin, esophagus, and trachea, and then the spine, the spinal cord, and then the spinous processes, and then the skin on the back of the neck. And so we can either come through the front of the neck and take out the disc. It's a nice way to go because you actually are addressing the pathology directly. You can't get out the disc from the back because of the spinal cord. It's just one of those things we can't move. So you can't touch it from the back. You can't safely get at it from the back. What we can do from the back, though, is we can make the opening for the foramina bigger, for the nerve to exit bigger. So we indirectly can decompress that nerve by just making the space bigger. The way that works is we just unroof the foramina, and so what it does is it allows the nerve root to float away from that disc osteophyte complex. So our choices are an anterior cervical discectomy infusion, an artificial disc replacement, or a posterior cervical foraminotomy. For unilateral arm pain, for just one arm that hurts, I particularly like to do just the foraminotomy. It preserves motion. It doesn't fuse anything. And then for if both arms are bothering them, I do tend to go from the front of the cervical spine. So we offered him a posterior C5-6 foraminotomy for unilateral arm pain because it saves motion. It does hurt more. This is a posterior incision, so operating through the large musculature of the cervical spine posteriorly. really bothers patients. Going from the front doesn't hurt as much. There's not any muscles really in the front. There's the platysmus and the sternocleidomastoid. We don't affect the sternocleidomastoid with an operation, but the platysmus doesn't really do much. And if you think about it, you don't really have to do much to flex your head. You just kind of let your head drop to flex forward. But you do a lot to keep it up. And so every time you get out of bed, you're always exercising these posterior cervical muscles just to keep this 10-pound weight up and positioned in space. So we went ahead and did the posterior cervical foraminotomy. It has about an 80-90% success rate. It does tend to leave people after 6 months to a year. It does always seems that people will always have a little bit of numbness if you really push them, but usually the arm pain is quite a bit better. And then long term, in terms of a stability standpoint, we haven't changed anything in terms of their biomechanics, in terms of flexion extension. We have changed maybe a little bit of a stability issue because we have operated through some of the bone in the back and we have to remove some of the lamina and a little bit of the facet complex at some point. But we don't necessarily have a long-term problem with instability in the cervical spine that we have in the lumbar spine, and that rate in the lumbar spine for instability after a microdiscectomy is roughly 10 to 20% in around 10 to 20 years. But we don't notice that in the cervical spine as much. So in this particular case, did 6-month follow-up, was doing extremely well. We, at this point, will ask them to come back and see us if anything else needs to be addressed in the future. His rate of needing us again at some point of his life in the early 40s is probably about 10 to 20%. Usually that would be at a problem at a different level because whatever degenerative process that's going on at C5-6 is also going on at C6-7. No, thank you.
Dr. Wendy Chang, she actually put together a lot of these slides. She was originally going to be doing this talk and due to some situations had to fulfill some other obligations. So I got the opportunity to speak with you all today. But Wendy helped me put together a lot of these slides, so I'd like to thank Dr. Chang for that. I'll start off by saying that I have no conflicts of interest, no disclosures to make. What I'm going to talk about this morning are first some brain trauma cases, a subdural hematoma, epidural hematoma, some cases of aneurysmal bleeding, infection, pituitary apoplexy, and then some spine cases here we'll show. So the first case I'll talk about, this is a high school teacher we'll talk about. He was, his wife recalled after he had a fight several weeks ago, family distress argument, he took some nitroglycerin to see if it would help him calm down and relax. He had a brief loss of consciousness at that point in time and woke up with a tender spot in the left head. He presented with cognitive decline, had that ground level fall, had the ground level fall. His physician, naturopathic physician, recommended he be seen in the ER. His medical history was significant for a cabbage, aspirin, and nitroglycerin, as I mentioned there. He, on exam, was slow of speech and gait. He had no focal neurodeficits, but he did have a little bit of pronator drift on questioning him carefully. So, subdural hematomas. This is a bleeding hemorrhage in the brain, or on the brain, I should say, classically caused from rupture of the bridging veins from the dura down to the surface of the brain. These happen more commonly in the elderly because as we get older, our brains shrink down a little bit, and the tension on those bridging veins builds up a little bit, and they're more prone to shear or breakage after a fall. Chronic subdurals classically may happen after a fall. A patient may never even realize they have a subdural hematoma, have no problems, and slowly it may build over time, bleeding slowly. Sometimes these hemorrhages will stop bleeding, but then they organize, they form membranes around them. The membranes then can have secretions and secrete fluid and even bleed themselves and expand. And ultimately, many times they do become symptomatic, but oftentimes these are found incidentally as well. This is the subdural space here. This is the coronal section of the brain here. This is the area, and the bridging veins kind of run right up in through there. We see these commonly in patients who are on antiplatelet agents, aspirin. Also see them on some of the newer Eliquis, et cetera, the drugs that we as neurosurgeons get a little nervous about sometimes, actually. But we also see them all the time in people that aren't taking any of these things as well. They sometimes just happen. So in seeing a patient here, the history, classically the patient will tell you they had a fall at some point in time, although many times though, they don't really recall, but oftentimes you'll be able to trace a fall sometime in the last 3 or 4 weeks or several months sometimes for the chronic subdurals. For the acute subdurals, the history is usually readily apparent. Examination can range from being obtunded from an acute subdural with mass effect to simply headaches. I mentioned before this patient we're talking about had some pronator drift, and what I mean by that is when they were examined, they were asked to close their eyes, hold your arms up in the sky like this, and one of their arms would drift over like this as they close, a sign of some subtle weakness on the motor cortex there. This is a left-sided subdural, so you would expect this patient to have perhaps maybe some right pronator drift. They may have focal deficits with speech or other things like this as it relates to things, but oftentimes the symptoms for chronic subdurals are simply headaches and very sort of mild findings many times. They may present with balance difficulties or things along this line there. On radiographic findings, classically what we'll see is blood here in the subdural space, and it will track, it'll usually be crescentic in shape, not lens shape. It'll be more of a crescent form on the axial CT scan. So for an acute subdural hematoma after, say, a high-speed motor vehicle collision, in a large subdural, you'll see midline shift where the middle of the brain is pushed from one side over to the other. Those cases often need to go to the operating room for emergent craniotomy, evacuate the subdural hematoma. Sometimes we even leave the bone off and do what's called a decompressive craniectomy. When I was in residency, we used to call that procedure the brain bag because afterwards their head would be soft for a while, it would swell up a lot. And usually for several weeks to several months, it takes the brain to settle down, and then we can come back later and put the bone back in place. Those are usually, very commonly, very, how would I say this, obviously emergent procedures, oftentimes the last thing you can possibly do. But surprisingly, we have some patients that make some pretty amazing recoveries from this. Unfortunately, some don't. For chronic subdurals, the blood products usually become a little bit more liquefied. We can often evacuate these without doing a large craniotomy, but rather just making a small burr hole in the skull and draining fluid out, 1 or 2 holes, and then placing a drain typically afterwards to allow it to drain out slowly over time. The difficulty with chronic subdurals is very commonly they recur. So there's a lot of debate in the literature over the last 50 years. When I was at the university, I remember reviewing this literature. Do you place 1 burr hole? Do you place 2 holes? Do you put a drain in the holes? Do you not? And some authors argue that as many as 30 to 40% of the time, they have significant recurrence and require repeat drainage there. But very often we can treat these with simple burr-hole drainage. So in this case here, this patient presented with an acute decline in mental status. It was a 31-year-old, and this was treated with burr holes here. Onto a different type of case here. This will describe a 31-year-old male who was struck by a truck. He had headache after that injury there. Then he became lethargic and unresponsive. He later then woke up. On exam, he had, at the time that he initially came in, he had no brainstem reflexes whatsoever. He had no pupils bilaterally. He had, his left corneal reflex was intact. And so to test that, basically a Q-tip cotton was put on the cornea on the side there, on the left side, and got a little blink out of him from that side. But otherwise, there's really no obvious sign of brainstem functioning initially here. This patient had an epidural hematoma, which is classically caused from a skull fracture that then lacerates one of the blood vessels on the surface of the dura between the skull and the dura itself. So these blood clots typically occur not in the brain itself, but between the skull and the dura itself there, and then they apply pressure. They usually occur in the younger population, largely I think because that's where we see most of our trauma patients. These days we're seeing The age of our trauma patients, however, is shifting, becoming older and older every year there. So I think we're seeing more of these in an older population as time goes on. It is true that as one gets older, the dura becomes more adherent to the skull, and so we see them perhaps a little bit less over the age of 60. The textbook presentation happens in about a third of these patients, and that's a patient who knocks their head, has a lucid interval. So they're perfectly fine if they knock their head, and then they become obtunded. So this is a axial CT scan of an epidural hematoma here. These hematomas can be distinguished typically because instead of being crescentic like a subdural that runs typically along the whole surface of the brain, it's more lenticuliform here. So sort of pushing into the brain that way, more of a lenticuliform fashion, as they say. It can be sometimes difficult on a CT scan to determine whether things purely an epidural or purely a subdural there. It's obviously, real life doesn't always look just like it does in the text cases. Oftentimes you'll see a skull fracture associated with this, but sometimes you don't see a skull fracture there. Most commonly, epidural hematomas happen from, significant epidural hematomas happen from an arterial bleed on the surface of the dura. We can sometimes see a small vein that can cause a smaller hematoma that usually doesn't expand, usually doesn't have as much pressure, and usually not quite as emergent there. Small epidurals can be managed sometimes medically. Watching them, classically, we'll repeat a CT scan within a few hours to make sure they're not expanding. That particular patient that I showed you before, that patient went to the operating room for an emergent craniotomy and had to return back to their normal baseline. So the next case I'm going to show you is a patient who has the worst headache of their life. And this is a 60-year-old gentleman who has normal activities and doesn't typically complain of headaches, not a migraine patient, not a headache sufferer there, and all of a sudden had sudden onset, worst headache of his life, hit him like a train, thunderclap headache, knocked him down, nothing like he's ever had before. He had a history of hypertension, coronary artery disease, was on aspirin. When he came into the hospital, his blood pressure was 190. He was miserable from his headache, but he was alert and awake and intact. This patient turns out to have a ruptured aneurysm. I'll show you a little bit about this. The peak age of, as you all probably know, an aneurysm is a blister on a blood vessel, happens around the circle of Willis classically. The peak age is between 55 and 60. Risk factors, hypertension, contraceptives, smoking, family history. Symptoms of headache, vomiting, passing out, meningismus, photophobia. Sometimes patients get a third nerve palsy, which will present with perhaps a droop in the eye or a dilated pupil and difficulty with their extraocular movements. 50% of headaches, 50% of patients or more with an aneurysmal bleed will have a sentinel headache. And this is a warning headache that may happen at some point sometime in several weeks before that. Unfortunately, we don't pick these up a lot of times. You know, they just have a bad headache, but in retrospect, you ask them, well, yeah, I had a really bad headache before, and now this one came on, it was way worse. 45% of patients who have a ruptured aneurysm don't survive. This is an incredibly morbid disease. We also see people with subarachnoid hemorrhage or bleeding into the subarachnoid space on the surface of the brain with something called perimesencephalic non-aneurysmal subarachnoid hemorrhage. I could be wrong about this, but it seems to me like I've seen more and more of this over the last 20 years than we saw previous. Some of that may be due to increases in CT scanning techniques. Some of that may be due to, we see this commonly, we see this sometimes in folks with substance abuse, methamphetamine abuse, crack cocaine abuse. We've seen a lot of these as well. But this is a non-aneurysmal subarachnoid hemorrhage that happens around the base of the brain from small capillaries or small veins. It's very difficult on a plain CT to distinguish from an aneurysmal subarachnoid hemorrhage, but a vascular study, an angiogram or a CT angiogram will not show any aneurysm, and typically we'll repeat those studies to prove that it's not a small aneurysm that we're just missing. And these perimesencephalic bleeds can have a very good prognosis. This is the CT scan on a person with a subarachnoid hemorrhage. What we see in this scan, this is an axial scan, so it's a cross-sectional picture through the brain. These are the eyeballs. This is the front, the back. This is the brainstem down here. All this bright stuff here is blood in the subarachnoid space. This is the patient's left side, this is the patient's right side, and we can see it pulls up over here a little bit, suggesting that there may be an aneurysm over here in this area here. Using current technology with CT scans for subarachnoid hemorrhage, the sensitivity for picking up subarachnoid hemorrhage from aneurysmal bleeds is greater than 95%. We'll see about a fifth of patients will have enlarging of their ventricles from the blood. And the amount of blood that we see in the brain, in the fissures here, the thickness of this blood here, that's been shown to be prognostic for developing a complication that can happen after aneurysmal bleed called vasospasm. Vasospasm is a complication related to aneurysms where the vessels around the circle of Willis, thought to be due to the blood products that coalesce there, start to spasm off in a delayed fashion, usually 4 to 10 days after the aneurysm ruptures, and that can lead to strokes and other kind of complications there. So much of the care of aneurysms, patients with aneurysms after they've been ruptured is geared at first preventing rebleeding, obviously securing the aneurysm, but also preventing and treating vasospasm if it arises. So in a patient who is questionable, we don't see a lot of blood on the CT scan, we don't know if it's there or not, lumbar puncture can be done. This is done less and less, I think, these days because, again, the sensitivity of CT scanning is getting better and better and better. But one can do a lumbar puncture. And what we'll see many times is, or at least classically, is this yellow CSF there, indicative of a hemorrhage that's taken place at some point in time. This shows up several hours after a subarachnoid hemorrhage there. One can also look at the red blood cell counts in the cerebrospinal fluid. This gets a little tricky many times in the emergency department because you have a patient who may not be the easiest person to do a lumbar puncture, and they may be moving around. They've already got a really bad headache. You're trying to put a needle in their back to get spinal fluid. You might get some blood from the muscles. You might get a little epidural. Getting a bloody tap is not uncommon. The way we distinguish this is by looking at the blood cell counts in the first tube we collect versus the fourth. And in a patient who has an aneurysmal subarachnoid hemorrhage, classically the red blood cell, the number of red blood cells does not decrease from the first tube you collect to the last tube. Whereas if you have a traumatic tap, typically the first tube or two will be more bloody than the last several tubes there. That's one way to try to distinguish it. In reality, most of the times these days, if we've got a patient with a questionable history there, typically they'll get a CT scan. And if the history is really good, very often we'll just go straight to CTA. I think the number of times that we do lumbar punctures to rule out subarachnoid hemorrhage is really going down a lot in the last decade or so. So as I mentioned, CT angiogram is 97% or better sensitive for picking up an aneurysm. That number just keeps getting higher and higher and higher. MRA is a little bit less sensitive. Cerebral angiograms, a classic angiogram. We do this anymore most commonly for treatment. We can treat many of these aneurysms through endovascular techniques, placing coils in the aneurysms rather than having to go to surgery and do a craniotomy and put a clip across it. In highly suspicious cases where you just don't see an aneurysm there, sometimes we will do, on a CT angiogram, we'll do an angiogram. And then sometimes we may even repeat that if it's just so suspicious and we don't believe it's perimesencephalic, but we just don't see anything on the CTA. So I mentioned that hydrocephalus can develop in patients with aneurysms. This is thought to be the blockage of the obstruction of CSF drainage from blood sort of clogging up the drains of the brain, so to speak. Acutely, we typically treat this by placing a lumbar drain in the back. That helps. And sometimes we end up placing an external ventriculostomy drain into the brain to drain it. Most commonly, these patients don't need to have permanent CSF diversion, but there are a number of patients who end up requiring ventriculoperitoneal shunts. Securing the aneurysm is of paramount importance when someone has a ruptured aneurysm and they've actually survived. If someone rebleeds, the mortality is off the charts there. Some say as high as 80%. The rebleeding risk if someone has a ruptured aneurysm is about 4% on the first day, and they've survived the initial bleed. And then it goes up 1.5% for about 2 weeks. Then if you follow those patients for 6 months with an unsecured aneurysm, and this is based on old data from the 60s, 70s, and 80s before we thought it was safe to treat a lot of these aneurysms, rebleeding can happen as much as 50% over the next 6 months. But the risk is really highest in the first 10 days or so there. We can treat the aneurysms most commonly these days endovascularly by placing a coil in through the femoral, placing a line into the femoral artery and snaking it up into the brain, and then placing a coil into the aneurysm belly itself there, into the body of the aneurysm. This then thromboses off or clots off the aneurysm and secures it. Unfortunately, securing the aneurysm does not do much for the damage to the brain that's already been done. So when we see these patients, commonly they may have significant neurologic deficits if they have a very bad hemorrhage there, and securing the aneurysm generally does not protect them from, or cure those deficits there. And that's often a difficult conversation to have with families. That's something that medical management, making sure they have their blood pressure optimized, their ventilation optimized, everything else, their temperature control, blood sugar, et cetera, the whole metabolic workup sort of managed well. That's the best we can do to support them and allow them to recover. But securing the aneurysm is critical because obviously if it bleeds, that's devastating. I mentioned vasospasm. This typically happens 3 to 14 or 4 to 10 days, depending on how you read after a bleed. We follow this by doing ultrasounds of the brain. Literally, they take an ultrasound and listen to the vessels there through the skull, called transcranial Doppler. And you can actually pick up increases in the velocities of the blood in the middle cerebral artery or the anterior cerebral artery or the basilar artery. And increases in velocity there will correlate with narrowing of the vessel and subsequent vasospasm there. We treat this initially. All aneurysm patients get a drug called nimodipine. It's a calcium channel blocker. It's a big, huge horse tablet. It's only able to be given orally or through a feeding tube, so there are some difficulties with it. But it's been shown to decrease vasospasm. They typically get this for several weeks after an aneurysm like this there. Also, in severe cases, vasospasm can be treated by taking the patient down to the angiography suite, and we can inject intraarterial calcium channel blockers such as nimodipine, or even do balloon angioplasty in some severe cases there where a vessel is put in and allowed to expand there. The angioplasty can be incredibly dangerous, and it's typically reserved for cases where the spasm is quite severe, non-responsive to any of the treatment, and we really don't have any other options. So this is a case of subarachnoid hemorrhage. A patient had progressive somnolence over several hours. We see in this case here some enlargement of the ventricles. The temporal horns here are a little bit bigger. The CTA was negative for a bleed. In this case, when I looked at this, I thought, geez, there might be an aneurysm up in here, but it turned out to be negative and was really what we call the paramesencephalic bleed. And with a lumbar drain and the external ventricular drain, the patient ultimately returned back to their neurologic baseline. So onto a different type of case here. This is we'll show you now a 49-year-old female who 3 weeks ago had an ear infection. Was treated with eardrops and Augmentin, had continued ear pain. Came in with confusion, disorientation, nausea, and vomiting. This patient had a previous medical history of IV drug abuse, but swears she's been clean for a long time. Doesn't touch this stuff at all. Our exam, she was febrile, disoriented, white blood cell count was 23, and she had gram-positive cocci in her blood cells, in her blood cultures. So this is a case of a brain abscess. Brain abscesses, typically we see these commonly in IV drug abusers, hematogenous spread. We can sometimes see multiple abscesses in the brain. We always want to look out for endocarditis, and our medical teams will help with echocardiograms to make sure the heart valves aren't a source. Lung abscesses can also be a source for these. You can sometimes get direct spread from sinusitis or an ear infection. Classically, one of the first case reports of a brain abscess back in the 1940s, I believe, was picked up in the pre-CT days with ear infections. And there was a neurosurgeon, a general surgeon and a neurosurgeon, who actually treated the abscess with a burr hole and then placed a chicken bone, a decalcified chicken bone, into the brain to drain it. This was before we had silastic tubing and rubber tubes and so on. There's actually a great case report about this. I have this in one of my medical history books there. I'm blanking on the name of the neurosurgeon who published that there, but it comes to mind as I look at this. But ear infections, bad ear infections can certainly cause infections into the skull. They can cause mastoiditis and brain abscess as well. So So this is some imaging from this patient with a brain abscess. On the left is a CT scan, and on the right side is the MRI scan there. And what we see is this guy here. Not here, but right there. And sorry, I couldn't resist. Abscesses are classically ring enhancing. We see enhancement right here. As you probably know, when we give IV contrast, gadolinium in the MRI scan, this is a non-contrast CT scan, it appears to me, but we use iodinated contrast there. The contrast will go across the blood-brain barrier when there's disruption of the blood-brain barrier. So things like tumors or infection, they'll have a disruption of the blood-brain barrier, so you'll see the contrast actually getting into the brain in those areas there. So when you see enhancement, that's evidence basically of disruption of the blood-brain barrier, and an abscess will classically have a nice clean rim of enhancement there and a dense or cavity in the middle there. There are a number of other radiographic criteria that Dr. Slaughter may show some of that later perhaps. We mentioned here on diffusion enhancing imaging, they'll often show what's called restricted diffusion there, so we'll see those there. These typically will get an emergent neurosurgery consult. A mass as big as this one typically will require urgent or emergent drainage depending on the size of the lesion and the patient's neurologic status there. Often we will if we don't have another source, it's important to get a diagnosis there as well. Following drainage, if necessary, antibiotic treatment is universally given, IV antibiotics there. Medical management alone for management of abscesses generally reserved for patients who have very small abscesses, multiple small foci of emboli that are just not drainable, or something that's in a very poorly accessible location. And I can't think of any that would be really poorly accessible except perhaps in the brainstem. And I can't think that I've ever seen a cerebral abscess in the brainstem personally, but I'm certain it's happened before in the literature there. The mortality from brain abscess is about 10%. And I can tell you from my own personal experience, I've taken a few patients to surgery. It's not always clear if someone has a tumor or an abscess. They look very similar sometimes on the MRI scan. And the patients don't always have the classic clinical presentation. And the few times that I've taken a patient to the operating room thinking it very likely or could be a primary brain tumor, which carries a pretty grim prognosis many times, and we come back, we enter into the lesion there, and we get a bunch of pus back, that's actually a really happy moment for the patient and the surgeon because the prognosis for an abscess is great compared to the prognosis for a malignant brain tumor. Brain abscess is on those list of things that I really don't want to get in life. When I compare that to some of the other things that can happen there, we see there, it's actually can be a happy moment. I can think of a joyous time I had really happy moment in the waiting room at Legacy Salmon Creek when I walked out and talked to a family and told them great news. She's got an infection in her brain. Sounds kind of odd, doesn't it? In fact, we all had a group hug at that point in time, I think. So the case I showed before had right temporal abscess and mastoiditis. The bug there was strep pneumococcus, which was rare. A craniotomy was done to drain the abscess, so you don't see it there anymore. You can see the burr hole here. You can see the burr hole from the craniotomy. Also, the ear, nose, and throat surgeons did a mastoidectomy to clean out the infected mastoid process there where the infection was going into the bone. And then anti-seizure medication, Keppra is what we classically use now. It's a lot less toxic than Dilantin or Depakote or the more classic drugs there. I would tell you that brain infections, brain abscesses, very high seizure rate relative to other hemorrhages or tumors or things like this. So typically, anti-epileptic drugs are given for at least a short period of time. And this patient did pretty well. Okay, so on to another case. Sorry to keep running through this litany of cases here. We'll have time for questions at the end of all our talks today, and so we can come back to some of this if you all have questions there. So this is a case of a 43-year-old gentleman who had sudden onset headache, and he said he couldn't see things right. His vision was getting weird. It felt like he was getting tunnel vision, and he was walking into the doors and just didn't feel like he could see very well. This patient had pituitary apoplexy, and this happens from sudden expansion of a pituitary tumor, an adenoma from hemorrhage in the tumor or sometimes from necrosis. This is a common presentation initially for pituitary tumors, or it may be from someone who has a known tumor there. There's elevated intracranial pressure sometimes. They can get cranial nerve palsies from expansion into what's called the cavernous sinus right along the base of the skull there. Classically, that causes extraocular movement disorders and often severe pain, severe orbital pain. Visual field cuts can happen. Classically, from a pituitary tumor, patients get what we call a bitemporal hemianopsia. They lose their temporal visual fields. So I always say those patients would be able to stop you if you tried to hit them this way, but they'd be a sucker for a right hook because they don't see things out here on the side there. Of course, we never do that, actually. Very commonly, though, patients will just say they just feel like their vision is just weird. It just doesn't feel right, particularly if there's apoplexy. So these folks will get a CT scan and an MRI scan. This CT scan here shows some expansion into this is the sella where the pituitary gland lives here. I don't see a lot of hemorrhage on this one right here. This is a sagittal MRI scan that shows the pituitary, the sellar region right there. And it looks like there's some hemorrhage in that one right there. We'll get a set of laboratories, electrolytes. We're always concerned about the sodium. These folks can get diabetes insipidus and have severe derangements of their sodium. Also, an endocrinologic workup is paramount there. Typically, we'll order these labs here. Medical management right away, hydrocortisone. That's a big deal. That can be life-saving for someone with apoplexy there. We put in urinary catheters classically to watch for diabetes insipidus. And I would say when I was initially taught back at the University of Washington in the 90s and in medical school, I was initially taught that pituitary apoplexy was an emergency that went to the operating room right away. I can remember going to the operating room on, I think it was Thanksgiving Day, 1998, with my chairman, Dr. Wynn, at the University of Washington. I think we did another one on Christmas Day, 1999. It seemed like every holiday, Dr. Wynn seemed to find a pituitary tumor and apoplexy, and so we did these quite frequently there. There's been a fair bit of data and experience that you can take these folks to surgery within a week and have pretty good results. And I think that most of the practice now is to treat these urgently, not necessarily emergently. It varies from patient to patient depending on the mass effect that they're having, the severity of the visual field cut, and how sick they are. Onto a different type of case here. This is a 47-year-old gentleman who presented with weakness over several hours, severe headache, and vomiting. Has hypertension, and this guy just doesn't like taking his hypertensive medications. Just makes him, refuses to take them there. When he came into the hospital, he was moderately hypertensive with a blood pressure of 240 systolic and had an expressive and receptive aphasia and not moving the right side of his body. This gentleman had an intracranial hypertension, intraparenchymal hemorrhage. Risk factors, you see them there, high blood pressure, anticoagulation. Age doubles with each decade after the age of 55. Alcohol use, cocaine and meth, we see a lot more of these than we used to in younger folks with cocaine and meth. I've had 2 patients up in Vancouver who were using a drug that I was unaware of called kratom. I don't know if anybody here has had patients with that as well, but apparently there may or may not be some link to kratom use and hemorrhage as well. That's much less, that's a little bit questionable there. Also, these happen classically deep in the brain, in the basal ganglia. In elderly populations, there's another type of intraparenchymal hemorrhage that happens called a lumbar hemorrhage, classically caused from what we call amyloid angiopathy, where the blood vessels become essentially weakened and develop amyloid deposition in the veins themselves and the small arterioles, and they can cause more lobar hemorrhages that are more in the periphery of the brain, more at the gray-white junction and into the gray matter, as opposed to deep in the basal ganglia. Intraparenchymal hemorrhages classically happen in the basal ganglia, from hypertension in the basal ganglia, in the brainstem, in the dorsolateral pons, and in the cerebellum. You can also have less likely, you can get hemorrhages from tumors, vascular malformations such as AVMs. So here is a rather large blood clot right here. Again, not here, but right there. You see the hyperdense clot right there. This patient has a significant amount of midline shift. The midline runs right here. You can see the ventricles right here are shifted over from the patient's left side to the right side. Initial management involves getting a CT. Obviously, airway, breathing, circulation. If the patient's not protecting their airway, you have to take care of that first and take care of the ABCs in terms of their resuscitation. We like to keep the systolic blood pressure less than 160, typically systolic. This is rather empiric. Ideally, we like to keep their blood pressure normalized, but when a patient that comes in, we don't know what their typical blood pressure is, where they live at. Their blood pressure is going to be chronically elevated classically. Their perfusion is probably going to be relative to what their blood pressure is normally. So we typically set 160 as sort of the number we shoot for. And we'll use calcium channel blockers. Often a nimodipine drip is started to, or excuse me, nicardipine drip is started to control that. So Decadron's fairly controversial. Some folks will use it. I typically don't for intraparenchymal hemorrhages, but there are some who do. Mannitol or hypertonic saline, the idea here is to increase the osmolarity and to decrease intracranial pressure there. There's some evidence that hypertonic saline may work a little bit better than mannitol in cases of hemorrhage there because it doesn't build up in the brain quite as much. And we do surgery sometimes for these hemorrhages, most commonly in the cerebellum, but sometimes we'll do them in large lobar hemorrhages causing impending herniation. The deep intracranial hemorrhages in the caudate nucleus or in the basal ganglia, there's been rather extensive data showing that surgical evacuation of these lesions is not associated with increased outcomes and is associated with worse function. So we tend not to do surgery for those, for most of the basal ganglia hemorrhages. I will say that there has been a push recently with less invasive techniques, fancier retractors, better surgical techniques to sort of readdress this question. I know many neurosurgeons around the country who adamantly believe that the randomized data suggesting that we shouldn't operate on hemorrhages is faulty and not good data there, and their clinical experience is very different there. And I suspect that we may see a resurgence in some operating on some of these hemorrhages in the next few years here, and we'll see how that plays out. But generally speaking, we don't evacuate these clots. We do surgery sometimes on folks who have a large hemorrhage in the brain and it's causing mass effect, and maybe we'll do what's called a decompressive craniectomy. So remove the bone to allow the brain to swell a little bit so they don't die from intracranial pressure. We won't go into the hemorrhage and necessarily evacuate the clot itself because that can cause other kind of damage there. And that's a judgment decision there. There's really not a lot of evidence for that. Typically, we'll do that more commonly on a right-sided or a non-dominant lobe hemorrhage. I will very commonly get a CT angiogram to make sure there's not a vascular malformation hiding out in that clot. If it's a classic location in a patient who has uncontrolled hypertension and comes in with all the classic signs like that, we don't always do that. But sometimes you'll get a hemorrhage that just looks just a little funny, looks a little odd there. And getting a CTA can be useful. Again, one of my last cases as a chief resident was a person who had a big clot. She was fairly young. She was hypertensive, but the clot just looked a little bit weird. This was back in the days when we used to evacuate these before the randomized data suggested that you shouldn't. I took the patient down to the operating room as a chief resident there, called my attending to come on in. He was on his way driving in up at the UW. And I called him on the way and I said, Dr. N, I just looked at the CT angiogram was just done here. It's not a hypertensive bleed, it's a huge AVM, vascular malformation. So he had a few choice words for me at that point in time, just in general there, but very different sort of prognosis. We ended up evacuating some of the clot, taking the patient to angiogram after that, treating some of the AVM endovascularly with thrombosing it with coils and glue and things like this, and then coming back and resecting the rest of the arteriovenous AVM at a later point. That's a rare case, but does happen sometimes. So when we have these patients that may not have a history of hypertension, may be on the young side, the imaging may look a little bit weird, we'll get a CTA. Also, sometimes if the lesion's not classic, we'll get an MRI and look for tumor, because tumors could certainly bleed. The difficulty here is that it may just show you blood, and the MRI may not be all that helpful. So I'll commonly, if I have a patient that I'm suspicious that the bleed may be from a tumor, I may repeat that MRI scan at some point in time. So brain tumors. I'll make this the last case I show here. So we think about brain tumors. There are primary brain tumors that occur in the brain, either malignant or benign, and then metastatic tumors. There's a list of tumors that classically we see in the brain. I think breast and lung are clearly the most common. I was always taught that while melanoma is far less common than lung or breast because there's far less cases of melanoma, if you have a melanoma, it's the one type of tumor that's most likely to go to the brain. Does that make sense? Okay. So think back to the scans I showed you before about the abscess. It was a nice, round, enhancing lesion. Here's a brain tumor. Rim enhancing, just like the abscess was, but it's a little bit more irregular over here. On the CT scan, we see a mass right here. It's not quite as hypodense in the middle there, not quite as dark in the middle there. So this a little bit more suspicious for a tumor than an abscess. But if I saw this patient come into the, if I saw this scan initially, in my mind, I would say the differential diagnosis is tumor versus abscess. So we take the history. Shocker. We put the patient on Decadron if there's a lot of edema around it. If they're having seizures, Keppra, and then we typically will get called for these. So for brain tumors, metastatic tumors with a biopsy-proven primary, and there are multiple lesions there, typically these folks will not get an open craniotomy or surgery there. Typically oncology, radiation oncology, and we often will treat them with radiosurgery, radiation, and or chemotherapy as necessary. A single solitary lesion in the brain with no known diagnosis almost always will get a craniotomy to get a diagnosis, and also for mass effect if the tumor is causing significant mass effect. For metastatic lesions, the best randomized data that's out there is that for a patient with a single metastatic lesion, surgery plus radiation is better than either of those treatments alone. That data was generated before some of the major advances in radiosurgery have been developed in the last several years, so there are some who would debate that. But the randomized data still suggests that surgery plus radiation is the best treatment there. And to my knowledge, there haven't been any new level 1 studies that have sort of countered that. So this is the patient. That patient underwent a left frontal craniotomy and had a resection. And this is one of Dr. Chang's patients who had to return back to their baseline. How much time do we have? I got 5 minutes. Okay, so I'll show one case of spinal cord compression here. This is a 45-year-old female with several days of neck pain and gait instability and clumsy hands. History of IV drug abuse, and was injecting heroin directly into the neck here. Couldn't have any more veins here, so went right into the neck directly there. On exam, had wobbly gait, hands couldn't control, had a Hoffman sign, so he flicked the fingernail and the thumb would kind of collapse down like that. Upgoing toes on Babinski testing and severe hyperreflexia. There had a white blood cell count of 23, an elevated CRP and SED rate, and blood culture is positive for everybody's favorite staph culture, MRSA. So cord compression can happen from disc herniation, epidural abscess, tumor, fracture, or post-op hematomas. People can get numbness, weakness, urinary retention, clumsy hands, spasticity, upgoing toes. This is the imaging in that patient I was just talking about here. And what we see here is an MRI scan, sagittal, and right in this region in here, there's a lot of pus right around the cord here. This is the vertebral bodies right here, the spinal cord running right here, and this is all our infection here, just squeezing off on our spinal cord. So because of our neurologic deficits, this patient was taken to surgery emergently to decompress the spinal cord, also to stabilize the spine. And it seems counterintuitive that you would have an active infection and want to put hardware in to stabilize the spine, but there's actually really good data and a lot of experience that you can actually, with titanium implants, you can actually put them in infected cases there, and if you restore stability and treat the infection aggressively, they don't have significant difficulties with the hardware. In that case, what was done was a laminectomy was done posteriorly in the back, and the pus was drained from the front of the spinal cord by using a little hook to reach around the spinal cord and drain the pus out of the front. And then rods and screws were placed in to stabilize the spine so that she didn't have further collapse. I think we'll end with that last case there. Okay. All right. Thank you, Brian. So one more case here. It's a 34-year-old female with right greater than left lower extremity weakness and pain. Can't walk, is numb when she sits down, and incontinent of urine. She's had multiple spine surgeries somewhere else in the past there. So this is what, any guesses as to what we're worried about here? Okay, bingo. Thanks. So cauda equina syndrome, it's everybody's, it's a buzz term, and what everybody we worry about in the emergency department, in our office, or anytime we see a patient with back issues. It can happen from compression of the nerve roots in the cauda equina, from a massive lumbar disc herniation is probably the most common cause of this, very commonly in the setting of somebody with pre-existing stenosis. So they have a narrow spinal canal to begin with, and then they herniate a disc on top of that. At least that's when I've most commonly seen it there. It can also happen from infection and abscesses. It can happen from fractures, or it can develop from postoperative epidural hematomas here. I would say that the cauda equina syndrome is really a continuum. I mean, the classic cauda equina syndrome we worry about is incontinence, is saddle anesthesia, loss of rectal tone, and such. But there can be mild variations of this. Patients may not have incontinence, they may have urinary retention. They may have some elements of the cauda equina syndrome, but not the full-blown cauda equina syndrome. These are some of the symptoms and the exam. I would say that if you're really worried about cauda equina syndrome in somebody, it is imperative to do a rectal exam. That's critical from a clinical standpoint, take care of the patient, but also from a medical legal standpoint. And while you're there, also check perianal sensation and perineal sensation. So this is an MRI from a person with a cauda equina syndrome. What we see here at L5S1, we'll call that there. It's hard to number these based on this image here. That's probably L45 actually. We see a large herniated disc there and severe stenosis in that region. So the best medical evidence suggests that outcomes for recovery of bowel and bladder function when it's lost, outcomes are better if you operate within the first 48 hours versus after that. That being said, I don't know any neurosurgeons or orthopedic spine surgeons who would sit on a patient with cauda equina syndrome for 47 hours while it was there. We usually take them to the operating room at the first safe opportunity. I have had some patients who have had other medical complications, and at the time I didn't feel like it was safe to take them at 3 o'clock in the morning until we made sure that their heart was clear and things like that, and that I think is reasonable there. But most of us will treat this and get them to the operating room ASAP. We want to do decompression in the case of the discectomy like before, or take out tumor, or stabilize a fracture, or drain the abscess. Most of the case reports and series have demonstrated the outcome depends on how bad they were before the operation there. So that case underwent a microdiscectomy and had resolution of their symptoms. And so, in summary, patients with acute neurological changes may require emergent intervention. Always want to take a good history, do a good exam, CT and MRI when appropriate, and a neurosurgery consult. And those are Dr. Chang's 4 beautiful children. She couldn't be here today, but wanted to share that picture with us today.
So I'm talking about osteoporotic hip and femur fractures and surgical management. It's not quite as emergent as the things that Dr. Nemechek was just talking about. Those guys are saving lives day and night. But this is something that probably is a little bit more pertinent to all of us in terms of the fact that if any of you in your practices has anybody over 50 years of age, you will have patients who encounter these types of problems as they age. My disclosures, I am a paid consultant for Acumed, which has really no relevance to this. None of the implants that you see in any of these images are from Acumed. So let's just jump right in. We're talking about osteoporosis, right? When I started medical school, bone broke, must fix sounded really awesome. It seemed pretty straightforward. It was much to my chagrin a little bit later that I learned it wasn't quite so straightforward. As patients age, they develop osteoporosis. And what that really means as far as us for fixing is if you look at these pictures here on the right and the left, you can see a very dramatic difference. We used to think of it primarily as a disease of trabecular bone. That is to say, on the right side is normal, on the left side you see increased distance between the spicules. The spicules are more rod-like, fewer of these kind of plate-like structures in them, and they are not as strong. There's a lot more space between them. We've also found when we take microsections of the cortical bone, however, there's also some changes in the cortical bone with increased porosity, okay? For us, what that considerations mean, if we're putting pieces of metal, screws or metal in here to hold, there's a lot more holding power in this thicker bone than there is in the other bone. So we have decreased strength of the bone and fracture toughness, which leads to these fragility fractures. So what's the burden of disease? I think Dr. Klein and you guys probably have a better grasp on this kind of stuff than we do as orthopedists, but just to give some basic numbers, about 11% of all Americans aged greater than 50 have osteoporosis. Over 40 million Americans have been diagnosed with low bone mass, and over 10 million have got osteoporosis. In the United States, osteoporosis is more prevalent for females in all age groups, and there's some data there you can see. I think the one that really scares me, is this bottom number right here. Over a third of women over 80 have osteoporosis, and I see that certainly weekly, if not daily, in my practice. A lot of older women with fragility fractures, okay? Projections, again, from this National Health and Nutrition Examination Survey are that by 2030 we'll have nearly 60 million people with low bone mass and over 13 million people with osteoporosis, okay? You guys know the diagnosis of this as much as I do. DEXA is sort of the gold standard, or at least it has been. When we get that is a measure of bone density. It's then reflected or the T-score is calculated against what is theoretically the maximum bone mass of the average person. Low bone mass is more than 1 standard deviation, but less than 2 standard deviations below the average. And a osteoporosis diagnosis is when you are less than 2.5 standard more than 2.5 standard deviations from that average. Primary osteoporosis is the most common etiology. That results from normal physiologic processes such as aging and menopause. The list of secondary osteoporosis is bewildering. I think the important thing first is to recognize is that up to a third of patients will have some other cause of their osteoporosis, and that's really important for us all to recognize. This list is very extensive. For an orthopedic surgeon, it's very intimidating. If the differential diagnosis is more than the number of bones in the thigh, we usually just call somebody. But here you can see lifestyle decisions such as smoking, alcohol intake, exercise levels, diet, including calcium and vitamin D intake, certainly endocrine issues like hyperthyroidism or parathyroidism, systemic diseases, particularly our inflammatory systemic diseases, rheumatic diseases, and then organ dysfunction, pulmonary and cystic fibrosis and COPD, renal diseases, neoplastic diseases, even medications can cause these type of problems. One of the most common secondary causes of osteoporosis is chronic glucocorticoid use. So those are things just to look at when someone has a diagnosis of osteoporosis, because if there is something that we can identify and treat, that can really help prevent the development of fracture. So fragility fractures, what does that mean? That is basically a fracture of any bone that occurs in the clinical setting of osteoporosis. It's usually a low energy fracture, and oftentimes it's a presenting symptom of osteoporosis. In other words, a patient does not have a diagnosis of osteoporosis until they've fallen and broken a bone. The most common sites in order are the vertebral body, the distal radius, the hip, and the proximal humerus. We're talking about hip and femur fractures today because those are the ones that most commonly require surgery, and also the ones that can really impact quality of life and lifestyle, and recovery can be quite difficult sometimes. So what's the burden of disease of fragility fractures? According to some of these surveys in the last 10 years or so, 4.3 million clinical visits per year. That means follow-up visits, of course, as well as presenting visits. In 2011, 1.7 million hospitalizations for females only, greater than 55 years of age. 23% of those were hip fractures, 8.4% for vertebral fractures. So that's 375,000 hip fractures in females alone older than 55 years, and that was in 2011. The average length of stay, according to some of these data, for fragility fracture hospitalizations is 5.5 days, which did not differ at that time when controlled for age or fracture site. And the vast majority of those patients ended up having to get transferred to a skilled nursing facility from their hospitalization. So it's a big deal in terms of cost as well as interruptions in these patients' lives and their families' lives. More specifically, hip fractures. There's an increasing incidence per year due to our aging population. We've all been aware of that coming for a long time. According to the CDC, there are 250,000 hospitalizations for hip fractures in patients older than 65 years. The vast majority of these are from just ground level falls, which we see over and over and over again. Interestingly, for Caucasians, the annualized incidence of hip fracture has been decreasing by about 1 to 1.5% per year, but overall incidence increasing due to the larger population. These fractures are a big deal. If you are over 65 and have a hip fracture, you've got a 98% chance of getting rehospitalized for something within the next 6 months, compared to only a 27% chance if you did not have a hip fracture. So it's an indication of maybe something more global going on than just breaking a bone. Long-term outcomes, these have significant increases in mortality, debility, cost, and changes in lifestyle. When I was in training back in the 90s, it was just kind of a rule of thumb that 1 out of every 2 patients with a hip fracture would be dead within 12 months. Those numbers have gotten better now, but still 20 to 30% mortality within 12 months. At least 50% of your patients who have a hip fracture will not get back to their prior level of activity or their level of independence. That's a big, big deal for the patients and the families, because everybody remembers what Granny used to be like and are very frustrated after her hip fracture, why she's not back the way she was that they remember. So what do we want to do here for hip fractures? Our goals of care. We want to get rapid medical optimization. We have got these medical co-management models, or fracture liaison service models. This is kind of co-management of patients in the hospital. I don't like the term medical stabilization because a lot of these patients are stable, and medical clearance, I'm not sure exactly what that means. To me, we want them to be in the best shape they can be as rapid as we can for surgery. A lot of these patients have got a zillion medical problems that will never eliminate their risks of surgery, and we just want them to be as best as we can. All of the data in the orthopedic literature suggests that the outcomes are much better if you can get the OR within 36 hours. So we really push these days to fix these faster. In the old days when I was a resident, patients sat around for 3, 5, 6 days before we got to the OR for a number of different tests or waiting till the wind blew the right direction or whatever, and that's really not appropriate. The outcomes are much, much worse if they have to wait longer. We want to get stable fixation that allows early mobilization and weight bearing. I think that's key. We used to put fixation in that wasn't that great. They couldn't get up and move very well. They laid in bed forever. They got bed sores, delirium, and all the other urinary tract infections, all the problems we see with just chronic lack of mobilization. So we want them to be able to get up and get moving and get back to their lives as best as possible. We want to do minimally invasive surgical techniques when possible. Smaller incisions, less bleeding, less risk. When we get them up and going afterwards, minimal use of narcotics and sedatives. We all know the problems with that. And again, delirium that's induced by their hospitalizations. Aggressive mobilization with physical therapy. We get the social services and case management involved in working with the patient and the families to arrange for appropriate discharge plan. We want to treat osteoporosis and its underlying causes if possible. But I think maybe this bottom thing is one of the most important things, at least when dealing with the family, is that we need to understand that the fall and the fracture that happens is not the cause of the patient slowly debilitating. It's a symptom. Many of these patients have had 2 or 3 falls before they break their hip. The fracture and the surgery they had did not suddenly cause Granny to stop having her memory as well or not be able to navigate as well. And it's important to let these patients and family know that something has been going on with them long before they fell and broke their hip. So what is a hip fracture? That sounds kind of stupid, but there's a lot of terms that are thrown on when we talk about hip fractures. So to an orthopedist, what it really means very specifically is a fracture that just involves the hip joint. That would be just this area here. The hip socket, the acetabulum, the femoral head, and the neck, which is still all within the capsule of the joint. But you will also see a lot of other terms kind of loosely applied to hip fractures. So something kind of in this rough area here, okay? A fragility fracture of the pelvic ring, which is this whole set of bones, right? The acetabulum, which of course is the hip socket, the femoral head, the femoral neck, and then the top end of the thigh bone, even what we call the intertrochanteric region right here, and even kind of high up, but just below the lesser trochanter in this area, are all things that you could consider hip fractures. So when your patients or your family says, I got a hip fracture, or when the ER doc calls us and says, we got a hip fracture, that could mean a whole lot of things, and they're not all the same. So that's a big difference for us when we're thinking about this is hip fracture is just kind of, to me, a very generic term that says, oh, there's a fracture somewhere there, okay? So the vast majority of fragility fractures of the pelvis and hip fractures in general are from a ground level fall to the side. You get an impact on kind of landing on the side here. When we're looking at the pelvis, a single view AP pelvis is not enough, and I'll show you some x-rays that show that. So for my purposes, we get 3 views, which are an AP, an inlet, and an outlet view, which I'll also show you in a minute, or a CT scan. The vast majority of these pelvic ring injuries are minimally displaced. Okay, again, a patient falls on their side, they land here, let's say, and what happens is this ring wants to crush this way, and what you get is sort of a rotation of this pelvis. It hinges on the back, kind of where the sacrum is, so you get sort of a compression here, and the front structures fracture and allow this hemipelvis to rotate in. And again, I'll show you some x-rays and CT scans. But with a minimal displacement, these are stable. We allow patients to start weight bearing immediately. We used to not do that, and then we took a long time getting them going, and what we found is not only did that give us all the problems with immobilization and bed rest, but it wasn't necessary. And patients really, at this age, have a very difficult time abiding by weight-bearing restrictions anyway. So a couple of really smart guys did some studies probably 10 years ago now and demonstrated that you can let these patients just put as much weight on as they want, and they're very unlikely to displace, and they can mobilize and get back to life a lot faster. So, okay, if most of them don't need surgery, which ones do? And those would be the unstable ones. Those are ones that have a high amount of comminution, multiple fracture lines and pieces, ones that are highly displaced, or fractures that are very painful or displaced when the patients do start walking on them. Those are the ones that need a reduction in stabilization from our standpoint. So I'm going to run through just a whole number of fractures, okay? Some of them you will see in your practices first, some of them I will see first in the ER. So we'll start with a patient with sacral stress fractures, okay? This is a 95-year-old female. She had a ground level fall about a year ago, complained of bilateral back pain, pelvic pain when she walked. X-rays that were taken by her primary care physician were negative. She was weight bearing as targeted. She got better. 6 months later, she fell again, had the exact same symptoms, pain bilateral in her pelvis, in her lower back with ambulation and weight bearing. X-rays were negative. This time the primary care provider obtained a MRI, and it showed sacral stress fractures. So what we're looking at here, these are axial views, the right side of the patient on the right side, or your left side of the screen, and here's the left side of the patient. And what we see are these kind of little lines going here inside the sacrum. This is the SI joint, right, between the ilium and the sacrum. So here on these other images, you can see again these lines here that were not apparent on plain x-ray. So she has sacral stress fractures. These are non-operative in almost all cases. Patients can be weight-bearing as tolerated. We usually tell them to use an assisted device so that they can use their arms to offload their painful fractures while they're healing. Treating the underlying osteoporosis, if it's not already being managed, is of course very important. A month later, this patient came back to see me. She's ambulatory. She's got decreased pain already with weight bearing. These are the 3 x-ray images I told you guys about earlier. So here's an AP view. Again, I get these to make sure it's not propagating, okay? Here, what I'm looking for is a negative finding. I don't see any fracture lines on the plain x-ray, which would be indication of the fracture getting worse. Again, these are the sacroiliac joints, not fractures. This is an inlet view, which is actually the best view for me to look at the sacrum. And again, the fractures, if they were propagated, would be right up there and there. And they look fine. This is an outlet view, and we see no evidence of fracture. That's good, okay? We continue weight bearing as hard with an assisted device. When do these need surgery? Almost never, but if someone goes on more than 6 months and still has pain with weight bearing, in very select cases, you might consider a surgery, surgical stabilization, which would be putting in a couple of big screws from either side to help give a little bit of stability and support there. There are reports of some guys starting to do this a little bit more aggressively, but even though I'm a trauma surgeon, I'm sort of conservative in terms of my indications for elective surgery, and I don't do it unless you really need it. And if you can wait 3 or 6 months and you don't need a surgery, I think that's way better for patients, especially our elder patients. So, a lateral compression pelvic ring injury. Fell down and has a hip fracture of the pelvic ring, okay? This is a stable one, okay? 84-year-old guy. He's got some dementia, history of a stroke. He's got some right-sided deficits. He had a ground level fall and was complaining of pain and inability to bear weight afterwards. In the ER, they got plain x-rays and a CT scan, okay? And this shows a pelvic ring injury as well as a proximal femur fracture on the right side. Oops, sorry. So here's the femur fracture, okay, pretty obvious. But what I think is interesting is this also shows half of the pelvis. And if you didn't know better, you would say there's no fracture there, right? It's very subtle. This is why an AP pelvis is not useful for looking at pelvic ring injuries by itself. But if we look at the CT scan, we see here's a sacral fracture. Okay, it's a compression fracture. What that means is you can see the contour is a little bit different over here. It's a tighter curve than that side. It's compressed in a little bit. There's also pubic rami fractures, a parasymphysal fracture. So there's fractures on the right side of the hemipelvis. All right. Now this guy's got a femur fracture also, so he's got to go to the OR to fix that. So we did one of my partners did a nice femoral rod here. It looks great. Okay. And then we allow them to start weight bearing as targeted because the pelvic ring fractures look stable. Okay. We give them DVT prophylaxis for about 3 weeks to prevent blood clots. Anytime we have a significant pelvic fracture or femur fracture that needs surgery, that's kind of a standard treatment at this point. Follow-up, we come back at 2 weeks, 2 months, 4 months, 6 months, get x-rays. At 6 months, this guy's healed both fractures. The femur looks good. We don't see any persistent fracture line here. The fractures in the anterior pelvis have healed. The AP inlet view and outlet view. The patient's having no pain and ambulatory. That's success, okay? I think the big thing is, again, with that strong rod in the femur and the pelvis that we didn't have to fix, weight bearing immediately, minimum time down for this patient. The best chance to get back to their lives. All right, so here's another one that was a non-operative, unstable lateral compression pelvic ring injury. 81-year-old guy, cleaning gutters on his roof. This guy's awesome, actually. He was smart enough, he put a safety rope on, which is not always the case. The rope broke, and he fell down. Hauled himself into his house, crawling on the ground, called EMS and got brought in. He had a shoulder pain and hip pain. X-ray showed a shoulder dislocation and pelvic ring fractures. Again, here on this plain AP view, you can see a fracture here, okay? And maybe something going on here. CT was also ordered. And what we see here is a couple of different fractures. So we see fracture in the back here of the sacral ala again. There's also a fracture of the ilium in the back. The next views will show parasymphysal fractures and, why am I keep doing this? So a rami fracture. A lot of times this is read as an acetabular fracture by radiology because it's so close to the socket. It's not an acetabular fracture. It's just a root of the pubic ramus fracture. Here's a parasymphysal fracture and an inferior pubic rami fracture, okay? So the fall from the height's a little bit of a higher energy injury. This is, to me, what makes this what I consider an unstable fracture. There's more energy imparted. There's more fracture lines, a little bit more comminution. We're going to treat this a little bit differently. It's minimally displaced. That means I don't need to put it back where it belongs, so it doesn't need surgery, at least not right now. The pelvic symmetry is good. The continuity is maintained. So non-operative, but I don't want them to put weight on this and stress this because it could displace, and then they buy a surgery that they don't need to get right now. So this is a patient that I would say toe-touch weight bearing. We used to do non-weight bearing, but what we found is almost no patient older than 60 years of age can actually do non-weight bearing anyways, so we tell them to toe-touch. It actually secondarily puts a little bit less stress on the fracture by being able to rest your foot on the ground instead of having to hold it up, where the compressive forces of the hip muscles actually put a little bit of stress on those fractures. So we mobilize with physical therapy. I give her DVT prophylaxis. We come back in 2 weeks. The patient's having some mild discomfort with ambulation, but no displacement on the x-rays. I allowed them to start putting 50% weight on that leg. What is 50%? I don't know, but what I think is probably different than that patient thinks. To me, what it means is they can put some weight on it, but not all of their weight. And if they comply with that, they're doing pretty well. At 6 weeks, minimal discomfort, still no displacement on the x-rays. Let her go, get back going to full weight bearing. Came back at 3 months, no pain, not using a cane, healing on the fractures, and continue weight bearing. So here is the 3-month x-rays. Again, our 3 standard views, and what we see is pelvic ring looks nearly perfectly symmetric again. The fractures we can hardly see. Again, here you can see just the evidence of the old fracture. It's a little bit tighter of a curve here than there, and maybe a little bit of callus there, but no interval displacement there. You can see that fracture line still persistent, but getting kind of fuzzy or faint. I tell my older patients that it looks almost like you took an eraser to it. They're the only ones who understand that, but it gets fuzzy, and that's new bone that's filling in there. So it looks great. Healing, minimally symptomatic. Again, we've avoided surgery. So how about one that needed surgery? So here, this is a little bit different story. It's a slightly younger patient, 57-year-old female, restrained passenger in a car, was in a T-bone MVA, hip on the side, okay? Same mechanism, getting hit on the side, but much higher energy. However, that being said, in the ER, she's complaining of pain on her right side. This is, again, why an AP pelvis doesn't really tell the full story, okay? We see, well, if you look at that, it doesn't look so bad at all, right? Maybe something's going on here. We got a CT scan, and that shows sacroiliac fracture. This is this typical pattern we see over and over again. Sacroiliac fracture, parasymphyseal fracture. You see some comminution here, though, now, right? It's not a very simple fracture pattern, and an inferior pubic ramus fracture there. Higher energy. So what are we going to do? It seemed minimally displaced at the time. You could see that even on the AP pelvis view. So we're going to say, let's try non-operative. Touchdown weight bearing with assisted device, mobilize with physical therapy, DVT prophylaxis, and early follow-up to get new x-rays. So this patient comes back at 2 weeks, Mark. This was actually managed by one of my partners. At 2 weeks, she's having terrible pains in her right hip, having a lot of time mobilized. And now you can see very easily, even on the AP view, this is shifted, significant. It correlates with her pain on her side, okay? And he said, oh, geez. So he sent the patient to me now and say, well, you take care of it. So, which is what should happen, okay? So we said, okay, that's clearly moved. We need to take you to the OR. And I'm sorry these washed out a little bit. But we took her to the OR, and we put a fixture on, and this is to grab a hold of the pelvis and literally de-rotate that. So her pelvis rotated inwards, and I need to rotate it out. So I put on this fixture. This is an inlet view, or this is the AP view, and it just shows the pelvic ring. Again, that fracture that you saw rotated in, we see it lined up nicely again. Here's an inlet view, just showing the front again, lined up nicely again, and the outlet view showing everything looking good up front here, okay? Here's some post-op imaging and follow-up imaging. Like every good orthopedic surgeon, I cleverly put my metal right over the fracture so you can't see, but the pelvic symmetry is well maintained. On the inlet view, it looks very good. The fractures here is not rotated anymore, and the outlet view looks pretty normal. These are the fracture, or this fixture consists of 2 pins that go into the good solid bone above the hip joint in the pelvis, and a frame that comes outside, which patients detest. There are some other ways to treat this depending on what's available in the patient's body habitus. For someone who's got some more meat on their bones, you can actually, there are some fixtures that will go under the skin, and sometimes you can put some screws in instead of a fixator. It really depends on bone quality and a couple of other factors. But this patient needed a fixator. We put that on. We followed up at 2 weeks, 6 weeks, 3 months. X-rays looked good. She was begging me to take this off as soon as possible, which is not strange. 3 months later, we take the fixator off. 6 months after injury. She's ambulatory. She's thrilled that she doesn't have a fixture anymore. She's thrilled she has no pain. And her x-rays show good realignment. The fracture is healed in good alignment on all 3 views here. Okay? Looks great. That was success, and that was exactly what should have happened in that. We try not to operate, but if it forces us to, then we get in there and do the surgery. Okay, just for completeness sake in the pelvis. So here's one that's kind of obviously needs a surgery. Okay, this is a 57-year-old guy, again on the roof, 16 feet up, fell down, landed on his backside. He's hypotensive in the ER. Okay, this is not something that you guys will have to deal with, hopefully. But he comes in, you can see this is a classical we call open book fracture, right? The pelvis opens up like a book, rips open the pubic symphysis. There's a widening here of the SI joint. This binders that you guys hear, okay? It just wraps around the greater trochanters and you close it down. Actually, one of my residency mates did the first study on this kind of stuff, and it closes it down very nicely and actually helps hypotension. It's a life-saving maneuver in some cases. CT scan, this is with the binder on, so you can see how that's closed down the front with the binder. But what we see is SI joint dislocation on the right side, or the left side, that's widening there. And on the right side, we see fractures of the sacrum and the ilium here. Okay, this needs surgery, no question about it. So we take them in the OR, and this is actually not as invasive as you might think. This plate in the front, which closes down the front in the rami. And this is looking at an inlet view, just showing the contour of the pelvic ring again. And that goes through a little fan and steel incision like you would get for an elective C-section, but smaller. And then we put a couple of big screws in the back to close down the fractures and the dislocation in the back, and those go through incisions the size of your fingertip. So not a huge surgical dissection for a pretty significant injury. This is what it kind of looks like in the follow-up. Again, the pelvic ring symmetry has been reestablished. We've got screws in the back avoiding the sacral foramina where the nerves are, holding the back together and the front together. It looks good. Unfortunately, with bilateral injuries, that's a big problem because these screws, as thick as they are not strong enough for weight bearing. So this patient is basically wheelchair for 3 months, and that's hard. Fortunately, it's a little bit of a younger patient, so they've got some upper body strength that can help compensate for that, but it's challenging for anybody. At 12 weeks, there's no pain, and the reduction has been maintained. We advance to full weight bearing and get physical therapy going for some general gait training. Actually, that was the last follow-up. The patient's going to come back and see me again in about a month at their 6-month follow-up. Another type of hip fracture. So now we're getting down to really much closer to the hip joint itself. So this is a valgus impacted femoral neck fracture. Left side, okay? 73-year-old lady had a ground level fall in her driveway while she's washing her trash cans, okay? Comes in, pain in her left hip. I can't put weight on it. They got an x-ray here, and here's what we can see is the difference in the contour between the right and the left hip, okay? This is normal. Here, the balls just collapse back this way, okay? It is not displaced in terms of falling off. I always talk about sort of a ball of ice cream on an ice cream cone sometimes. It's sort of tipped back or sort of melting, but it hasn't completely fallen off, okay? So the kid can still lick the ice cream if you want to think of it that way. That is a fracture that's not too bad. What I mean by that is it's fairly stable. We want to treat it so the patient can get up and get going as fast as possible. So it's a low energy injury from a ground level fall. It's a fragility fracture. It's a stable fracture pattern. It hasn't displaced too much. We want a minimally invasive surgery and get this patient going. So we do a percutaneous fixation. This is a fairly small surgery. 3 poke holes the size of your fingertip. We put in 3 big screws across that fracture. That just is to hold, mainly to hold. We notice we're not putting that fracture back. It's just staying put, okay? Right here. To reduce that, it would be a tremendous deal and probably cause more damage than worth. So we want to just keep it there so it heals where it's sitting. So these 3 big screws through 3 little incisions, 5 cc's of blood loss maybe, okay? It takes 20 minutes. You get them up, and they can be immediate weight bearing. Most of them will still have some pain, so you use an assistive device until they're feeling better. DVT prophylaxis again, physical therapy. We see them back at 2 weeks, 6 weeks, 12 weeks. This patient came back at 6 months. She's walking without an assistive device, but she's complaining of pain on the lateral side of her hip. Okay, oops, all right. And here, you can see the screws have backed out a bit. They are designed to do that. Notice that there's threads up here and not down here. We know that bone heals best when it's squeezed together. So when we started fixing these hip fractures, we said, well, if we're going to put some metal in, we want this to be able to collapse a little bit so that it will heal rather than holding them apart and maybe it doesn't heal. So they're designed to do that. And in fact, it worked. She healed. She's not having groin pain, which is or deep buttock pain, which is more indicative of pain from the joint, i.e. the fracture not healing. Instead, she's got pain right out here. She's a thin lady, probably from those screws sticking out just a little bit. That's a much easier problem to treat than joint pain, a non-union or something like that. So she's continuing weight bearing, and I told her, well, call me if that really bugs you. We can think about a small surgery either to take these screws out or change them for smaller screws. In general, for your elderly patients, I do not favor, once they've had a fracture, of just taking stuff out and leaving them unprotected. You're just waiting for another fracture and another surgery. So for these patients, I'd say, hey, we can make these smaller, but I would still put something back in to protect them. I think that makes a lot more sense than just taking it out and waiting for another fracture. Okay? And that can be done electively anytime, really. Okay, displaced femoral neck fracture. Here we are, an 89-year-old lady. This lady is great. So she lives independently at home and cares for her 91-year-old sister. She had a ground level fall, had pain in her left hip, couldn't stand, is in the ER saying, you got to fix me fast, I got to go home and take care of my sister. She's pretty awesome. So this is a fracture that's kind of the most classic or typical hip fracture, okay? We have x-rays that clearly show a displaced fracture of the femoral neck. So this doesn't look like a hip anymore. The ball is stuck in the socket. The femur is displaced proximally. This is the classic shortened leg, externally rotated, pain with any passive motion of the leg in the ER, okay? The problem with this fracture is the blood supplied to the femoral head is almost exclusively retrograde, okay? Meaning it's coming up the femoral neck into the ball via the circumflex femoral arteries, okay? Those are damaged or disrupted when you have this fracture. That means the healing potential of this fracture is very low. When I was a resident at the VA, we used to always reduce these and pin these, just like I showed you in that valgus impacted fracture. And it seemed to me like it was a staging procedure because 6 weeks later, you could come back and be sure that those screws had failed, they've collapsed again, they're very painful, and then you booked them for their hip replacement. And I just never understood it. Fortunately, in the 20 years since then, we have evolved, which is possible for orthopedic surgeons. I think we still drag our knuckles, but we do have opposing thumbs now. So now we just skip the initial step and go straight to a hemiarthroplasty or a total hip arthroplasty, okay? This is a bigger surgery, admittedly, but the benefit of this is immediate weight bearing and extremely low risk of failure, okay? The difference between a total hip replacement and a hemi is just whether or not we replace the socket or not, okay? We replace the socket if they've got pre-existing complaints of hip pain or hip arthritis and they need a total hip replacement. Otherwise, we do a hemi, okay? A hemi in some ways is preferred. It's a little bit more stable because we don't have to remove all the socket and the capsule and the ligaments there. Lower rate of dislocation with a hemi than a total, okay? So we go in there, we do these hip precautions, but a lot of the patients will not remember them or will not be able to abide by them. So again, to me, a hemi, if you can do it's better because it's a lower rate of dislocation. Immediate weight bearing, DVT prophylaxis for 3 weeks, physical therapy going, and we see them back in 2 weeks, 6 weeks, 3 months, 6 months. Sometimes you have to convert them if they do complain again of groin pain, or if over time you might see the space between the ball and the socket decreasing and they're getting groin pain, they may need to convert from a hemi to a total hip replacement, which is fairly routine for my colleagues who are wizards at arthroplasty. But that's if sometimes you wonder, why do we do this versus the other? In fact, I just had one of our internists ask me, why would they do this instead of a total? And I had this exact discussion with her just 2 days ago. Okay, another type of hip fracture, intertrochanteric fracture. Now we're moving down the femur. This patient is a 95-year-old lady, has got a mild touch of dementia, recently moved into an assisted living facility for patients with dementia, tripped on a rug, fell down, pain in her left hip, can't bear weight. And what we see is this fracture line going from the greater trochanter to the lesser trochanter. Very classic looking fracture, not very displaced, okay? We call this a stable fracture. It doesn't mean it doesn't need surgery in this case. What it means is that most of the supporting structures of the femur, particularly this area, what we call the calcar, where strong, thick bone is still intact. Oh, man. Okay, 5 minutes. So we have to fix this, but we want to make a minimally invasive surgery. We want to get it fixed quickly, so that they can go on and bear weight. So this is, we put in this metal rod, very strong. They can bear weight on this immediately. This goes in through 2 incisions, about 1.5 inches each, and we get them up weight bearing, DVT prophylaxis, etc. Okay? 3 months, 6 months, the heals, they go about their business as quickly as possible. Peritocanteric proximal femur fracture. This is just getting a little bit worse. Now you can see this is a 77-year-old alcoholic guy. He fell down. He had this much worse fracture. You can see the calcar area is broken now. It's a little bit more unstable. Definitely needs a surgery, obviously. But we need something a little bit stronger, so we just put a longer rod in. Okay? Here's the surgery. The fracture's lined up nicely. And we continue here. Nice long rod all the way down to the knee. This patient's weight bearing in 6 weeks. He can't even remember that he had the fall. He's weight bearing with a walker. At 4.5 months, he still has some discomfort, but he refuses to use the walker despite that. He's a pretty unhappy guy, and he's required in-home care. He's very dissatisfied, but he's ambulatory and was ambulatory immediately. I want to skip through some. I had a whole bunch of things, but I want one that's really pertinent to you guys. So periprosthetic fractures, these are cool x-rays, but maybe not as important. I think the big thing with these is you put an arthroplasty in, the bone gets really weak near the metal, and there's a big stress riser between the metal and the bone, and we see a lot of fractures near the edge of the metal, okay? And so that creates challenges for us for fixation. They're bigger surgeries because we have to grab really weak bone, and we can't use our standard implants because the metal blocks where we'd normally put our metal. So they're challenging surgeries. The metal fixation is not quite as good, and they can't be full weight bearing immediately. Someday we'll get something that they can fully weight bear on, and that'll be a big difference. But what I really want to talk to you guys about in this last 5 minutes are atypical femur fractures, okay? You guys will see these, and you'll see them before they break in your clinical practice. So these are the bisphosphonate-related fractures. There's an incidence reported as high as 2%. There's a higher risk reported in Asians and females. The relative risk after 3 years of use of bisphosphonate are 2.1 to 128, depending on what study you look at. Presentation, a history of osteoporosis, been on bisphosphonates, a ground level fall. Many patients report feeling the bone give before they go down. 1/3 to 2/3 have pre-fracture symptoms, groin pain, thigh pain with weight bearing, okay? There's a whole diagnostic criteria. They have to do with these low energy injuries, low grade trauma, fracture patterns, which is not really pertinent to you guys, and prodromal symptoms, okay? So here's a case history. There's a 75-year-old guy, had a history of stress fractures in his thigh in 2006, a poor historian, can't remember taking osteoporosis medications. In 2004, was complaining of some back pain and buttock pain, saw some spine surgeons, saw the physiatrist, got MRIs, eventually got an injection that completely resolved the symptoms. 2 years later, similar pains, but new complaints of pains in his anterior thigh with weight bearing. Felt different, it was atraumatic, had a slight limp, went back to the physiatrist. They did their workup again for back stuff, even did an injection, really didn't help his symptoms. Got an MRI of the thigh, which was read as resolving stress fracture, but no referral was made. In June 2016, patient's walking in a parking lot, falls in a little hole there, and gets a fracture, okay? Boom. This transverse fracture right here, okay? And what we see here is it's a nearly transverse, it's a low energy fracture. There's a lot of thickening of the bone here, okay? What I really want to highlight is look at this, okay? These are the changes associated with the bisphosphonate on the femur, okay? These fractures are very difficult to treat once they displace, okay? They heal very slowly. We ought to put the same rod in. This is actually not that thrilled with how I reduced this here, okay? It could be a lot better. This guy had persistent pain, even though we got him at weight bearing immediately. Here we are at 6 weeks and 3 months, not a lot of healing. I did another procedure to help this heal. Again, we want bone to compress for healing, so I took out some of the screws at the bottom of the nail to allow that bone to compress a little bit better. Again, slow healing. You can see how this screw, which is in the slot, is now bottomed out. That's how much it compressed. I eventually took out that screw. And finally, it goes on to heal. Okay, but this is something like 12 months later that he finally healed. This guy's pretty unhappy because he's now got hip arthritis that's proven by injection and wants to know why that's not also covered by his workers' compensation for his fracture. But the last thing I want to say about this particular guy is these are x-rays from 2013 and 14. he has the findings of what we call this lateral beaking. He was complaining of thigh pain then. These were taken in primary care practice, okay? And he could have had, let me just zip past all these. This is another one. That's analogous to this lady, whom another physiatrist saw this one, came in with thigh pain. He sent this and was going to have this patient come and see me in a couple weeks. We called her and said, no, come in tomorrow. We talked to her about it. We got her set up. We did a prophylactic nailing. This lady was, I think this lady was 91 years old. She wasn't going to let anything stop her. She spent one night in the hospital, walking the next day home, and she's having no pain and feeling great. This is a victory. It was identified early, put the nail in, no problem, versus that other guy, 12 months to heal and still pretty unhappy and maybe never happy. That's all I have time for. I'm sorry, there was a lot more in there. I appreciate your time. I will be around for questions and stuff afterwards and at lunch and so forth. Andy, is Dr. Klein next, or you want to? Okay. Thank you.
All right, this is the fractures. Now, I didn't say fragility fractures, I just said fractures. All right, and it turns out these are data collected here in the United States, looking at the incidence of fractures across one's lifespan. All right, so in red, those are the women, okay, and you all knew that. Oh, you were thinking about, because we've been focused on osteoporotic or fragility fractures today, and we know that those accelerate both in men and women, but less so or later in life in men than women, okay? But we tend to forget this little peak right here, okay? And are blessed with this area in here. So let's start to use some of the phrases I'm going to be using. This is when we have achieved peak bone mass in our 30s and 40s. And so when you've heard this reference that we'll talk a little bit about T-scores, it's basically saying, how does my patient now compare to if he or she were in her mid or his mid-30s? Because fragility fractures aren't supposed to take place at that time. Now, you're all going, well, what the hell is he talking about, fragility? We know what's going on here. As I like to say, these are young men trying to impress others, okay? Turn on the TV on Saturday afternoons, and these crazy sports, okay, are pretty much young men doing crazy things and then getting hurt, okay? And that's what we see. And even we can see it an 81-year-old that Dr. Kahn said up on a roof cleaning his roof, okay, and falls off and has a fracture. So those are fractures, though, that have to be thought about is where the bone is incapable of withstanding the force that's applied to it, okay? Now, in this case, these young men are applying huge loads to the skeleton in a stupid way, all right? And it exceeds the fact that they have not yet achieved peak bone strength. So it's a combination of both, all right? So what I'm going to sort of put in the context of, well, as endocrinologists and clinicians that don't have access to fancy screws and so on, is that we think about any fracture after the age of 50 to think about, well, they probably weren't doing something stupid or crazy. So maybe the situation they found themselves in really was something where reduced bone strength contributed to the fracture. And study after study shows that if you have osteoporosis, you're more likely to experience a fracture, a serious fracture, in a motor vehicle accident, okay? So we're going to be talking about that any fracture that you see over the age of 50, it should at least be in the back of the mind, oh, that was a bad motor vehicle accident. Maybe we should be thinking about this in some other context as well, all right? So with that in mind, then just put everybody on the same page, and I hope most of you are familiar with this cartoon. We're talking about osteoporosis now, a metabolic bone disorder that's robbed the bone of strength, is leading to susceptibility of fracture, is due to changes in the microarchitecture, okay? So that there's thinning of bone or complete loss of connectivity. And Dr. Kahn made a nice point that he said, you got to stick bone together if you want it to heal. All right? Well, if you start breaking trabecular struts and things like that, the osteoblasts responsible for making bone can't fly. There's no way they can start to connect this, all right? So again, our job is when we identify somebody with a fracture, think about, has some of this microarchitectural deterioration been taking place, and what can we do to slow it, okay, or prevent further? So we're thinking about in terms of osteoporosis is a fragility fracture, and for intents and purposes, usually you hear about at a ground level fall, okay? But too often we start to make excuses for, well, it was a ground level fall, but it was slippery and she was going fast when she sustained this Colles fracture. okay? Maybe, maybe not. Maybe there was some reduced bone mass present, all right? Why we're talking about, why you're all here listening to me is you're seeing it in your own practices. You're seeing this is happening much more, okay? Much more frequently. There are more old people around, and unfortunately, a consequence of living longer is that there's more bone resorption than there is bone formation going on. So there's a natural age-related decline in the amount of bone mass that can resist forces. But this is just showing you sort of pretty much close to what this prediction from over a decade ago, but you can see that there's nearly a 50% increase in the number of fractures that are taking place. Now, not fortunately, but many of those are spine fractures. We're not going to talk too much about it. In fact, I don't talk too much about my patients about spine fractures because they don't kill anybody, okay? What we're talking about are really preventing hip fractures that have significant morbidity and mortality. If we can prevent the hip fractures, we're going to prevent the vertebral fractures. But there's not a heck of a lot to be done about that, nor is there much in the cost of it to society in terms of involving orthopedic surgeons to take care of the hip fracture, in terms of nursing home placement, as well as changes in the whole family dynamics. Finally, many of us may say, gosh, and we'll talk a little bit about towards the end, is maybe the best way to identify a patient is to identify them at their first fracture. And this comes from sort of a little bit of a morbid way of looking at morbidity, all right? So this is the morbidity of as we get older, okay? So fortunately, look around, most of this crowd is not even on this graph yet, okay? But for those of us who are on into the 50s and 60s and older, the lower solid gray represents just the morbidity associated with getting older. Things just don't work so well, we may be a little more tendency to fall, etc. But that's the morbidity just as we get older. But notice what happens to the morbidity shown that's added onto that when you have a fracture, okay? So for example, maybe the first fracture is that wrist fracture. So for temporarily, life's not so good for you. You've got this tied up. It's difficult to open cans, do other things, get to a door, drive, and things like that. So there's a little bit of morbidity associated with it, but fortunately it heals. You're back to normal. You're back on that graph. But as you continue to age, notice that the second one, you kind of get back there, but you spend more time with sort of quantifiable morbidity. But notice as those fractures start to accumulate more and more, and you're not getting back to where your peers are who haven't had that fracture. So again, and again, I'm not telling you anything new. This is just another cartoon way of sort of looking at it. Why we need to get and intervene and be thinking about, is there something we can prevent the next one from? Okay? I teach my medical students fractures beget fractures, okay? If you find a patient with a fracture, it's very likely they're going to have another one. You've already defined to you that they lack either common sense, okay, and they're going to be up on that roof again, okay, or that they have microarchitectural change that they haven't noticed but contributed to that fracture. So fractures beget fractures. Identifying the one who has the fracture, you're going to pay off in terms of where we should intervene and where we should spend our efforts on. I wish I could tell you we can find the one before that, but screening, as we'll talk about, doesn't really work very well with the current tests that we have. 2 million, too many. If you do that math of the 5,500, we're talking about 2 million fractures this year. But more importantly, let's talk about hip fracture and what I call the 3 Ds, okay? The death associated with the debility and the destitution. Dr. Khan alluded to earlier on about death, okay? And these are data taken from Medicare surveys looking at mortality and then debility and then destitution, okay, that accompanies this. And they broke their subjects down in terms of the mortality, in terms of, sort of relative measures of overall health. And so if they were sort of a community dwelling patient, they're taking care of themselves, running their own household, they had a 2 to 3-fold increased chance of dying the next year just because they had that hip fracture, okay? And being rich didn't make any difference. If you weren't low income, it was about the same increase. So 2 to 3-fold increase of death in the next year that we can't say the hip fracture was responsible for, but is a marker of that. And there are agents now that have shown that if you can prevent the second hip fracture, you reduce mortality in these patients. But what about debility? The most expensive part of hip care, it turns out to be long-term care residency. We take these people out of their house and they are now living someplace else, cared for. And that's a 4-fold increase. If they were already managed in their house, there's a 4-fold greater chance they're going to end up with that. And then finally, what we don't forget about is we make them poor, okay? So in terms of they weren't low income, they are now poor afters about a twofold simply just because of having that hip fracture. So to put in context why we have to be very aggressive about preventing hip fractures in this elderly population if we can. Now, what can we do about it? Well, we all think about, oh, okay, there's another example. You had a heart attack. What can we do about that? Everybody gets involved with preventing heart attacks. And these are number needed to treat to prevent a repeat heart attack or to prevent a death. And we're talking about beta blockers don't really prevent another event, but they have nearly a 50% reduction, okay, in death. That's why everybody gets a beta blocker. Okay? Similarly, statins, ACE inhibitors, or even antiplatelet therapy, all of that have been shown. But notice that they're pushing anywhere between 40 and 150 to prevent a death, and 30 to 50 number needed to treat to prevent a repeat heart attack. A bisphosphonate in that population, we're in the same range, okay, of only needing to treat 40 to prevent the next hip fracture, or only needing to treat 120 to save a life. All right? So it's in the same context, but I don't see that we're being that aggressive. And part of that we're going to talk about, okay? This made the cover of New York Times, okay, some time ago, but basically that we used to be very aggressive, and I want to sort of argue a little bit with Dr. Khan that his slides are a little bit out of date, because yes, when we were pushing bisphosphonates like crazy and thought there wasn't a problem with them, we did see a decline in hip fracture. But it's, as you'll see, it's going back up again, okay? This is looking at the likelihood of treating osteoporosis. Used to be in the golden days of the early 2000s, we might treat 40 out of every 100 that should have been treated. All right, so we were at 40%. Now, well, nearly 8 years ago, we're down at half that, at 20%. Though, during that same time, the number of women went up from 19 to 25 million, just women that we're talking about in that group. So, how can we identify patients at risk? When should we be thinking about it? Well, almost everybody, they just go, boom, oh, I've heard about your fancy test called bone densitometry. Okay? And we frequently think, oh, bone densitometry, that must tell us about bone strength. And it does to some extent. All right? These are data, okay, that now have allowed, and now decades, FDA has approved and insurance companies pay for because this does predict fracture risk. All right? So, shown on the left, okay, is looking at femoral neck bone mineral density, moving from small numbers to larger numbers on the right. And notice that as your bone density is lower, okay, your lifetime risk of fracture goes up. Or shown in fancy colors on the right side is this converted to T-scores, which again are the standard deviations that you are away from the mean of a 30-year-old man or woman appropriate for your sex. And notice that that magical minus 2.5 that everyone uses of a T-score of, oh, this is osteoporosis, is simply just the inflection point on this, okay? That it really starts, because it's exponential, it really starts zooming up, okay? But while a T-score of -1 does have a twofold increase, it's only a twofold increase. Now, here's the problem with bone densitometry. This is a complicated slide, but I'll try and take you through it because there's many things trying to show on this, all right? This was basically a huge study looking at heel ultrasound as a surrogate for bone densitometry. But it was a quick and easy test that was done in thousands of doctors' offices across the United States. And basically, hi, hello, you're over the age of 40. Would you mind sticking your heel in this while you're waiting for the doctor? Okay. All right? And they got this information, and they said, by the way, can we check in with you and find out if you are going to have a fracture? Okay? So, first off is the curve sort of in the dotted line. It just shows a normal standard distribution of bone mineral density in this group. Now, if we'd done this on 30-year-old people, that mean would be over at 0, because we'd be looking at healthy, normal 30-year-olds, and so that would be the distribution around that, and the mean would be 0 because the average age of them. But these were older women, and so no surprise, the mean is closer to about -1 T-score. So they've been they've aged a little bit, they've moved a little bit away, they've lost bone since that time. All right. Now, in the wide light gray bars, okay, is the relationship between bone density and the likelihood of fracture. So notice that that is the fracture rate per 1,000 person years is shown in the wider gray, okay? And if you make the cutoff from -2.5, those people have very high likelihood of having fracture. very high compared to all the rest of the population. But here's the problem. If you look at where the fractures are taking place, that only represents 18% of the fractures, the fragility fractures that took place in these women in the study. Okay, 82% were missed. And this has been repeated in many other things. Bone density misses an awful lot, okay? It's only looking at the amount of bone, okay? And so any biomechanicist would say, well, of course, you're only looking at the quantity of something. The structural strength of anything depends on the quality as well, all right? And that's not anything that we can measure, okay? We don't have anything. We thought for a while we might find, but nothing works that's clinically valuable in terms of looking at architecture, the amount that quickly that turns over, whether it's mineralized. And probably the best example would be is someone with osteogenesis imperfecta, where they have a problem with collagen, okay? But their bone, the amount of bone is just fine. It's just not mineralized correctly, but they are very prone to fractures, even in the birth canal and later, and as a young child and later in life, and is associated with a dramatically shortened lifespan. So bone density is there, all right? Now, I always love to show this, okay? And then everyone says, okay, well, he's a biomechanicist. He says, oh, they're experts, they're engineers and things like that. But engineers are stupid as well, okay? Because there's another factor that's left off of here, and that's whether people fall or do stupid things, okay? So that's the other part of it that's present here. This is just looking at the strength of the bone itself, but then patients will do things as well, like being on a roof when you're 81 years old, that could lead to something. So, I prefer to sort of think about the various aspects as grouped in as such. Determinants of fragility fracture risk, we'll get into the pharmacologic management of it, but has to do with both increased bone resorption and reduced bone formation. When we're at peak bone mass, those are perfectly balanced with each other. And we need that little bit of remodeling to take care of microarchitectural damage that takes place just throughout normal activities of daily living. But unfortunately, as we age, all of us, bone resorption stays there or higher, and bone formation, unfortunately, falls off for all of us as we get older. And there are many things that we can do that can upset that and make that discrepancy even worse. But there are other things that we or our patients do poorly. If we choose our parents very poorly, then genetics plays a role, all right? Unfortunately, that's not something we can correct in the office, but definitely this is a heritable disorder. Why we ask about what happened to mom and dad. There are things that you and I or they can do, and we'll go through a list of toxins that can expose. But what also aggravates this is either malnutrition, so think anorexia or other dietary changes where people choose to avoid the building blocks of bone, okay? Or just frailty of not getting enough exercise, and you need forces applied to that. So all of this is basically summarizing the things that go into this, all right? So what can we do to think about when we see a patient with a fracture, to think about, are there tests I can do, okay? He's already kind of poo-pooed the bone densitometry, okay? Because the patient's already had a fracture. I'm speaking in this room now to people who've already had a fracture. What do we do post-fracture, okay? As Dr. Kahn mentioned earlier, his study suggested a third, depending on where you look, it can be as high as 2/3 of subjects will have a simple metabolic issue, okay, that can be addressed, that it will cost $75 to test for, and many times doesn't even cost that. Most patients, okay, that end up will have had baseline chemistry, a CBC, a 25-hydroxyvitamin D, and if they're on thyroid hormone, a TSH sometime in the past year. And those tests can let you rule out renal osteodystrophy, hepatic osteodystrophy, primary hyperparathyroidism, vitamin D deficiency. The one that's missing in almost everyone's workup, and one that I try to stress to everyone if you're thinking about skeletal fragility, is are they absorbing the calcium they're taking in their diet, and are they holding onto it, or have they been peeing it out? Now, I'm not suggesting you do this on everybody, but someone who shows up with a fragility fracture, you wonder, how did they end up this place? Okay? I'll tell a little story. Over at the VA, they started hearing about, we got endocrinologists interested in osteoporosis, and fractures would come into the emergency room. And they go, oh goodness, okay, we got to take care of these guys, make sure they get on calcium, and then get them over to see the endocrinologist. Between the time of seeing in the emergency room and a month or 2 months later when they finally show up to see us in clinic, many of them were reporting, I've got flank pain now, I've got blood in my urine, okay? And these were men that had, unbeknownst to anybody, a renal calcium leak that was worsened by the treatment, okay? They didn't need more calcium. They needed a way for their kidneys to hold on and to retain what they'd been losing all of their life, okay? But similarly, many patients we identify who have normal serum calcium, normal vitamin D, have trivial amounts of calcium in the urine, and that indicates that they've not been taking it enough. If you're not taking it enough, then you have a high parathyroid hormone level, you have secondary hyperparathyroidism, and that is stimulating bone resorption and robbing calcium, okay, from the skeleton to make up for what the patient's not been taking in from their diet. So if the environment's not providing enough, the skeleton will provide that. So that's why the 24-hour urine a very cheap test, the cheapest of all those up there, but rarely performed, can really tell you something. And as I said, it's not too much, and if you assume that you're only a third of the time, it's only costing you $272 to identify a patient where you can make a major impact. All right? So just a little bit, since I've got a captive audience, I want to dispel some of the things you may or may not have heard about some of the simple things. I think about with my patients the sort of these basics: calcium, vitamin D, exercise, preventing falls, gaining weight, which I always find funny that this fat guy up here is telling this, but I love to look at these skinny patients come in and say, yeah, well, when I fall, I got plenty of padding. And that is an issue in terms of both padding, but also fat contributes in a complicated way to skeletal health. Okay? And then finally, by all means, stopping smoking. So let's first off, there's been too much about calcium, so you're going to get my bias. Okay, wait, you don't need my bias, you need an expert on this, okay? Some of this may be a little bit old for you, but Midnight Cowboy, it was a pretty amazing movie from last century. And Ratso shared that there are just two things, sunshine and coconut milk, okay? And he's talking about vitamin, well, no, he's not, but I'm telling you, he's talking about vitamin D and calcium, all right? So what's the story about that? We've heard so much, calcium is bad, causes heart disease, etc. Well, depending on the study you look at, it may possibly be that it could be in some small studies it shows it is risk. Other studies show no, it's a benefit, okay? Why don't we take the grandmother of all studies, that being the Women's Health Initiative, where close to 40,000 women were given calcium supplements to see, will this make a difference? They were interested in heart disease, they were interested in cancer, they were interested in fractures. And lo and behold, okay, they found it impacted nothing, good or bad. So that's why you'll hear people say, you shouldn't be recommending calcium supplements. And they're absolutely right. But what they don't tell you about is the other part of this study, which they said, well, it was voluntary to sign up for this study. They didn't take calcium supplements away from anybody. They said, here, take this in addition to whatever you're doing. So it's no surprise that they became concerned that in a small subgroup of these women, they were even having kidney stones, much like my veterans that were showing up in our clinic after being given calcium supplements. Instead, they said, let's go back and look at the people who weren't taking any calcium supplements on their own, and they were then taking, we know they were taking what we were giving them. So these were women who weren't so motivated about their health, that weren't taking calcium supplements, and what happened with them. And there you see a 35% reduction simply by giving them 800 milligrams of calcium, 800 to 1,000 milligrams of calcium a day. All right? So we should be giving calcium to those who are insufficient, okay? But we should not be making blanket recommendations. And the same applies to vitamin D, okay? We should be thinking about giving it to those who are insufficient, okay? And then it will make an impact. But throwing it to just putting it in the water for everybody, as any supplement is wrong-headed. Preventive Services Task Force came out and said basically, well, we don't know, okay? So we're going to tell you that recommending against 1,000 milligrams of calcium or less than 400, that's stupid. Don't do that. That gets a D. But unfortunately, we've got too many crazy little studies that go both ways, okay? And they're going to say, so we're not going to, just insufficient evidence, all right? My experience, and I trust that most anyone who takes care of osteoporosis will see that you have a high risk of patients who are seeing you because of a fragility fracture because they've not been getting in enough calcium or they've been losing too much calcium all of their life, as well as other things like they're on steroids or other things that can be contributing. All right? So what about the toxins? Immobilization, again, as you've heard from the surgeon or Dr. Khan earlier, get them up and moving. Clearly they had a hip fracture. There's many reasons to be up and moving. pneumonias, pulmonary emboli, but it also stimulates new bone formation, okay? Why we're never going to Mars currently is because until they find out a way to be able to have muscles pull on bones, okay, no one's going to survive the trip there and back. God forbid they survive all the other problems that be, but their bones will be like jellyfish by the time they return if we can't find a way to maintain pull on bones. Cigarette smoking screws up estrogen metabolism. That's why people shouldn't smoke. Oh, maybe there are a few other reasons that you're aware of, but alcohol, definitely. The binge drinking that college kids are doing is taking a toll on their achievement of peak bone mass. We all get too much sodium, okay? There are pretzels over there in the midday, all right? We all get too much sodium in our diets. For every 100 milliequivalents of sodium that we have in our urine, we're losing 25 milligrams of calcium. To make up for that in our diet, that's another 100 milligrams of calcium because we only absorb about 20 to 30% of it. But what about all the things that we can prescribe? Steroids number on the list, but pretty much it turns out if you're worried about ulcers, so you put on a proton pump inhibitor or a H2 blocker, impairs calcium absorption. We don't know what's going on with some of the psychoactive drugs like the serotonin reuptake inhibitors, but we think it has direct effects on bone cells themselves. And then finally, our diabetics getting exposed to either TZDs or the new kid on the block, the SGLT2 inhibitors, are clearly associated with increased risk in bad fractures like hip fractures. So there's much more to be known, but there are many medications that we can prescribe that cause the problems. So that toxins and so on. Let's talk now about pharmacologic treatment, the adjustment of bone formation or bone resorption that we can do pharmacologically to benefit the patient, all right? So the guidelines for this are pretty simple, and I have for your slides, that if you've had a fracture and you're pretty convinced that this was a ground level fall, a fragility fracture, not induced by some crazy Red Bull associated event, okay, that's osteoporosis. Or to use, if you already have a T-score of below -2.5, to use that to make the diagnosis. But what about those who you think maybe have some of these other factors, that 82% of patients that didn't reach the -2.5 that we should do something about? Well, that comes from this FRAX, and I trust that some of you, and if those of you don't, we're going to go through a little bit of this fracture algorithm that was created by the World Health Organization to be able to get a handle on this increase in fragility fractures that are taking place across the world. And it's a very simple site that you can go to. You can get it as a app on your phone, but patients can just look it up on their computer, or many bone densitometry labs provide you this information with some simple questions that are getting at what we think are linked to changes in quality of bone. So like, have you fractured, has a parent fractured a hip, or have you had a previous fracture? That already starts to tell you you have increased risk, all right? So let's take the average 65-year-old woman, okay? She's had none of these things. She's average weight and height. It turns out that her 10-year risk of a major osteoporotic fracture, the humerus, the hip, the spine, is around 10%, or 1% per year. And her hip fracture rate is about 0.2% per year, or 1.6% over that, all right? This is the guideline that the Preventive Services Task Force said, you don't need to do a bone density up there, okay? If that bone density value hadn't been done, you'd get the same result, okay? It turns out that most 65-year-old women have a T-score between -1.8 and -2.2. They're healthy. So it turns out that adding the bone density result doesn't change this score. So what you do is you say, gosh, should I do a bone density? You're only 54, but could you have a skeleton that's more like a 65-year-old? Let's punch your numbers in with your history, and if you see that it exceeds 10% for major osteoporotic fracture or hip fracture, go ahead and get the bone density, because she's acting like a 65-year-old woman. And it's approved in that situation. Screening and the insurance companies say bone density can be done at that time, all right? But again, for this audience, I have this as sort of separate. If you already had a fracture, you don't need to be worrying about this stuff. She's already, or he's already in that group of a fragility fracture. But this is if you're thinking about someone where you might try to capture them before they've had a fracture. What happens to those risks when you start adding on steroids or previous fracture or genetics and so on? Like now we're talking about a 44% chance over the next 10 years, or close to 5% per year. And similarly, a 9% chance in terms of hip fracture, or now about 1% per year, if you add all of those in. Okay? So indications again, 10-year major fracture risk greater than 20%, a hip fracture risk greater than 3%, or a T-score below -2.5. So what's available, all right? What's available are mostly on the side of slowing down resorption. We've got lots of different agents that can try to slow down either normal amount of resorption or excessive amount of resorption that's taking place in the hopes that what limited bone formation is taking place can outstrip what bone resorption now is left, all right? So we have estrogen, as well as a variety of bisphosphonates, the alendronate, risedronate, abandronate, and zoledronic acid, okay? And then we have better living through chemistry, a designer estrogen, a selective estrogen receptor modulator, raloxifene, and then a newer compound that is a monoclonal antibody that interferes with an agent that slows down, that speeds up bone resorption, part of the rank ligand signaling system. But on the other side, for increasing bone formation, we have but two. The one that's been around for a while is teriparatide, or PTH 1 to 34. And I don't want to scare anybody, but PTHRP has been linked to, not been linked, is a compound that was discovered in studying cancer patients. And it's a fetal oncogene, shouldn't be present in adults, but it works just like PTH, and in fact works quite good if you give it medicinally to treat osteoporosis as well in terms of an anabolic agent. So that's PTHRP, okay? So I should prepare you that if patients start looking at PTHRP, they're going to wonder, why are you giving me something that causes cancer? It doesn't cause cancer. It was discovered through cancer work. So to summarize them, okay, bottom line is all of these are quite effective. Hormone replacement therapy is very effective, but will never be used by anybody in this room in women over the age of 65. Okay, at least your insurers will appreciate that. Their study after study demonstrates increased strokes, heart attacks, and thromboembolic events in women over the age of 65 who are taking long-term hormone replacement therapy. And the beauty is we have other agents to use for those patients. And that would be raloxifene that does not associate with such cancers and does not seem to increase the rate of atherosclerotic cardiovascular events, but unfortunately it only works to prevent vertebral fractures. It doesn't seem to work to prevent hip fractures, and many patients complain of hot flashes because it interferes with normal estrogen cycling. The bisphosphonates have been around for a long time. They're very, very safe, okay? They can be administered either orally, once a week, once a day, once a week, once a month, as well as you can administer them parenterally once a year, okay? They clearly work on both vertebral and non-vertebral, including hip fractures. The oral ones, sometimes there's an issue with GI upset. And parenterally, if they've never seen a bisphosphonate before, prepare them. The first dose of a parenteral bisphosphonate may be associated with a flu-like reaction that only happens the one time. The body then says, oh, I know what you are, and the next time they get it, they won't get that reaction. As I said, denosumab is, again, a parenteral is given as a subcutaneous injection once every 6 months. It has some of the concerns because it is a monoclonal antibody and an immunotherapy, but it's been very well tolerated. And then similarly, the PTH analogs are very, very effective, okay? Their problem is they come with a black box warning about concerns of osteogenic sarcoma that developed in animals exposed to high doses of these agents. And also, as we'll talk about, the cost, okay? So first-line agents, again, I hope most of you are familiar with, are pretty much the bisphosphonates, okay? A perimenopausal woman who's younger, not anywhere near the age of 65, you could also consider hormone replacement therapy for some of those other benefits. It is still considered the gold standard for bone. Unfortunately, it just has too many very worrisome side effects for long-term exposure. The second-line agents would be another bisphosphonate that's not used so often. We don't see Sally Field hawking this agent much more. It was never demonstrated to prevent hip fractures. And as I said, raloxifene, the designer estrogen, causes hot flashes that makes it difficult for many women. Calcitonin's been removed from the European distribution network because of concerns over nasopharyngeal cancer associated with the, and we just don't see too much of that being used. And then for patients with very high fracture risk, certainly we're looking for anabolic agents. We could use these, but that represents a high hurdle to get by with insurance companies, unfortunately, because of the very high expense. So I talked about the number needed to treat, and again, thinking about if you've already had a fracture, and if your T-score is low, okay? Looking here, we're looking at if your T-score is below -2.5 and you've already had a fracture, you're talking about somewhere between a number needed to treat as low as 1 in 12 to 1 in 24, okay? And if you lump these all together and take advantage in terms of building in cost, you can see why generic alendronate is at the top of this list. Well tolerated, a good safety track record, okay, and is sort of the preferred treatment at roughly $100 a year, okay, for generic alendronate. Compare that to $21,000. Unfortunately, this is a little out of date. It's even more for teriparatide and for abaloparatide, but a difference of 2 logs in terms of the cost of using these agents. Not to take away, though, that teriparatide is, on this list, the only anabolic agent that's up there. But we're talking about $100 a year for 5 years on treating just number needed to treat of 12 patients. You're talking about only $6,000 to prevent a fracture. Okay? So these are the patients that you'll be seeing, and you might be wondering, well, if I've dealt with a fragility fracture, why isn't this patient on a generic alendronate at some point? Or at least thinking about something like that. Okay? So they're safe and effective, they're available. Summary. Both of these are excellent. It's just the pragmatics of what I'm talking about is generally most insurance companies are looking for. And then the other thing I sort of just would like, if you are get involved or think about or see patients with this, to think about the right medication for the right patient at the right time. Okay? Pretty much once a fracture's occurred, you don't need to wait, assuming that you've dealt with those other workup that we talked about earlier. But certainly who's got a history of DVT, you're not going to put on something like an estrogen or even a designer estrogen. Thrombophlebitis is of increased risk in those patients. If you know that they have difficulty swallowing, okay, achalasia or some other esophageal stricture, do not put them on an oral bisphosphonate. That will just be doomed to fail, okay? Sometimes people won't take medications. So a parenteral where you're in charge, it's prescribed once every 6 months or once a year, and you know that they get it, is a good way to go. Okay? So let me just show you what was going on that prompted that New York Times article. There have been great concerns raised about these agents. Now, I not want to get into alternative facts and so on like this, but these have been concerns raised over very rare occurrences. The first one was osteonecrosis of the jaw, and that definitely happens in cancer patients given osteoporosis doses of bisphosphonates every month instead of the way we prescribe once a year. And our patients don't have the immune compromise that cancer patients have. So practicing rheumatologists and endocrinologists just do not see osteonecrosis of the jaw, but you ask an oncologist using it for their patients, they do see it. But for us, we don't, it's not, it is related to dose as well as probably patient protoplasm in terms of their immune system. For a brief while, one study suggested that maybe atrial fibrillation was slightly increased in these patients. But that was quickly poo-pooed with a number of papers in the New England Journal. But the big one that Dr. Kahn referred to is this atypical femoral shaft fractures that has appropriately something that we should be aware of, okay? But I would point out that Dr. Kahn's example never saw a bisphosphonate. This all happened without. And then the truth is, patients with osteoporosis get femoral shaft fractures. They're not atypical then. We're calling them atypical because, well, we put you on a bisphosphonate 5 years ago, and why did this happen? Okay? That must be atypical, all right? So there's certainly, we need to be thinking about it. In this case of an example, a 52-year-old woman, she has a Colles fracture. They go just osteopenia. She didn't really meet the criteria for aggressive treatment they did, but she had a family history and so on. She's recommended to take a healthy diet and so on, and she gets put on a weekly bisphosphonate. 11 years later, despite the fact that telling her primary care provider that her hips are killing her and aching, okay, and that's ignored, this happens. And the point to sort of take a look here is look at how dense these cortices are. And so there is something about turning off remodeling as you get older for long periods of time. So we do not recommend extended exposure to bisphosphonates. We're talking about maybe at most 5 years. But if you don't give a bisphosphonate, what's the consequence? These are rare, very rare fractures. Whoops, I apologize. Shown down here. Very low, 0.1, my thumb is too fat, 0.1%. But you will have prevented 40% of fractures. It was estimated in this 73-year-old woman who got started on this that you would have gone from a 15 to 18% likelihood of having a vertebral fracture at 5 years down to 7%, and a 3% risk of hip fracture down to 1%. Okay? And even if you extend it out to 10 years, the tiny risk, if indeed these are connected, okay, or attributed to the bisphosphonate, is dwarfed by the benefit you have in preventing vertebral and especially hip fractures. So it's come with it. We talk about drug holidays, and so no one should stay on this extended, but we're talking about getting somebody on 5 years, okay, would be where you then start to think about this. And so again, for your handout, there are these slides sort of taking from our field. So very quickly, I just want to make you aware of, and I'm just going to sort of zip through this, about fracture liaison services, which seems to be probably the best way to go at this. We have our siloed of care, and the orthopedic surgeon sees this, the emergency room physician sees this, the clinician sees that, the specialist then sees something else. And there's been attempts at trying to coordinate all of this care as a way to deliver from when the event takes place to preventing further ones. And I attribute the American Academy of Orthopedic Surgeons as really championing this. Okay? And these are just examples of where, if you choose to use just take over the whole thing, comprehensive care, that'd be type A, versus you've had a fracture, you probably should talk to somebody about maybe seeing whether you should be on some calcium and get some exercise and go with God. And bottom line is, just to sort of show here, is where this has been adopted by Kaiser in California, or by this Geisinger Health System out in Pennsylvania, or the Glasgow in Scotland. There have been substantial savings, a dramatic increase in bone density, and a dramatic reduction in fractures, and that contributes to a savings for those patients financially, which is what we need to convince administrators of this. So you may see that coming. So you've been very patient with me. Just to summarize, okay, that we're talking about 2 million too many. Despite what I've said about bone densitometry, use that along with fracs to augment that. Calcium and vitamin D should not be blanket prescribed. You can hurt as many as you can help. Make sure that you get that. It minimizes toxins, and there's no reason to start fracture protection therapy right after the fracture. Let me close with that. Thank you. I've run over time, but there'll be time for questions later.
Thank you for having me today. My name is Jeff Cravo. I've been an athletic trainer with Rebound for 10 years, and we have currently 4 physical therapy clinics. Our original site in Salmon Creek, a Pacific Crest location, which is the location I'm at, off Mill Plain, Lake Oswego, and here at the Rose Garden. And fortunately for me, I get to work at, I'm sorry, there's no disclosures or interest, at our physical therapy location in Pacific Crest. We have an 8,000 square foot facility, turfed, that has a pull-out net for throwing, hitting, golfing, you name the sport. So of course I love to spend my time here. I do cover a local high school, but it's kind of a more of event coverage. So I get to work with a majority of the athletes and primarily the throwers that come through the Rebound system. I wanted to put out a few of the risk factors of baseball and the throwing motion. I apologize, I had a slide that somehow I deleted that showed that baseball, throwing a baseball itself is the highest recorded motion in sport. It is 7,500 degrees per second from maximum external rotation to that ball release. So that's the internal speed through each one of those throws. And this is why we have a lot of baseball athletes. If you want to know how fast that is, if you were to take 7,500 degrees per second, and in 1 second, the arm would revolution 28 times in a row. That's how stressful that is to the throwing motion and to the shoulder. These are the risk factors that we talk to the parents about, the athletes, and the coaches. As you can see, our #1 risk factor for elbow injuries in our youth is playing that one sport year-round, the specialization that kids are going to these days for one sport. They play in the spring through the summer, they may play multiple teams, then they go into the fall. And in the Northwest, even though we don't have the ability to go outdoors and play, we have these brand new facilities. Locally and Portland, you have the Portland Baseball Club. In Vancouver, we have Northwest Futures. And they have indoor facilities now that these kids can play at. So they are never giving their shoulder a break. I mean, that and the elbow. It is year-round. Every parent thinks their kid's going to be the next D1 signing, which is very rare that we see in our area. And it's a shame, because I believe that if we could educate a little bit more, and the numbers and data has been out there for years, and we started in the late 90s doing research on this stuff. I really feel like we can make a dent in this if we can continue to educate everybody involved. Pitchers who compete 8 months out of the year, 5 times more likely to suffer, so we want a 4-month break. 2 to 3 is probably more realistic. We really encourage multi-sports. We don't want them to specialize in one sport. So encouraging if they don't want a team sport, we can talk through an individual sport like a golf, tennis, any of those other recreational sports. Pitchers who pitch more than 100 innings in a calendar year were 3.5 times more likely. I can tell you that 10 years ago, the number was your age times 10. So if you were a 14-year-old, we suggested 140 innings is your max for a calendar year. You can see that number's come down way down to even like 100. And these kids are playing upwards of, just on one club team, 70 to 80 games in a short period of time. So with all the emphasis on winning and getting exposure and not having a ton of just pitchers, you're going to get they're going to be way over that 100 number. But this info's out there. We're just not using it. There's the 4-month mark. According to Yang et al., the pitchers who pitched on consecutive days had 4.5 times greater risk. ASMI found the amateurs who played catcher while not pitching were 2.7 higher risk, suffer arm injuries, so we definitely discourage a pitcher-catcher combo. So from a young age, we try to get them to choose. Are you going to be a pitcher or a catcher? There's the multiple teams. Curveballs and sliders, we do try to advise to stay away from it, but it's more about the repetition. It's okay to throw these pitches properly with good form and mechanics. It's the amount they're throwing. I'm going to talk to you and show you some videos of what I do in the clinic and kind of introduce to you some of the major flaws that we see in the throwing motion. And all this stuff is backed up from the ASMI and all the research. Dr. Fleissig, who's with Dr. Andrews' group, he's kind of the lead research guru in this stuff. I've been attending some of his courses all the way back in the mid-2000s, and all his stuff is published, so I can't really take credit for any of this, but this is the kind of stuff that I'm looking at from the throwing piece. So in our clinic, this is a video of a pitcher we had. All I use is an iPhone or an iPad, and I use an app where I can slow down and draw lines. So you're going to see here, I'm going to stop it when his foot make contact with the ground. And this is where I talk through the athletes and the parents of where in the lead foot contact position does our shoulder and elbow need to be? Where does our trunk need to be? Where the research shows that we're at a higher risk. So right here, I'm showing them the lead foot and the acceleration phase through to ball release. And then we'll stop at ball release, just prior to ball release, and measure different angles. I'm looking at maximum shoulder external rotation. We know in baseball that you have to have near 180 degrees of dynamic external rotation, but that also is what causes more injury. So we can kind of slow down video, take measurements with the tools we use. I'm showing a trunk angle with him right here. He's too far behind his front foot. He needs to get his head out in front more, and that's going to allow him to use his lower half more. So this is one of our younger youth athletes. With that same app, I can do a side-by-side and a front, and I can sync them together. and take them through and show them. This stuff is like, you know, they light up this stuff, especially the parents. They're just looking at like, whoa, this stuff is really cool. We can actually see it, and the kid can understand. You can tell a kid what to do and what not to do, but to give them that visual feedback is a huge piece, and I love to use it. So I'm showing on the left side his leg angle, how he has almost like a valgus position, and his foot angle. And on the right side, showing how he's upright in his throwing position. There's that trunk angle line again, and that back foot you can see is in contact with the ground. That means he's leaving all that energy on the lower half. So what I'm cueing him to do is to pick up that back leg to automatically move the trunk forward towards the target. And then on the other side, I'm looking at arm slot. If you saw the box I was drawing, I'll show you later on some of the technology we're using with arm slot. That box was just to show the athlete where the ideal position is we want his arm when he releases the ball. This is an example of one of the flaws I showed you, the 4 flaws we look for. It's called the inverted W. Actually, ESPN magazine back in 2012 put out an awesome article that was where we saw this rise in Tommy John surgeries. And it said, well, what is it about this what were we missing? And we took a look at the mechanics of all these pitchers and found that when their front foot made contact with the ground, they were in this what we call the inverted W position. So what happens in this position is when that front foot hits the ground, and then you have to go through this massive rotation through the shoulder and the elbow, all the torque is going straight to the elbow, and it's equal to a 40-pound dumbbell hanging off the back of your hand. And that's what they've been able to measure in the labs. So this inverted W, what I'm cueing the guys to do is when their front foot hits the ground, they get their arm up. Shoulder, elbows up to 90-90. I'm not so specific on range of motion there. I just want to cue them that their arm is up above that plane, that shoulder plane, and not down. Elbow drop, we see this in both shoulder and elbow injuries with the shoulder. When they come through, they're kind of taking that humeral head and just kind of, just grinding it on the rim, and they're doing it over and over again. So the healthiest position for the shoulder to be in is neutral. So we want them in that neutral position, so now when you're going through that internal, external rotation, you don't have a lot of that grind that you're seeing. And for the elbow too is the valgus, the stress that comes through when you drop your elbow. This is one of the sleeves I'm using in the clinic. It's called the Moda sleeve. The app is called Moda's Throw. It's a free app. And right now, this is being used right at the top level in major leagues because they can afford to do it. But they published a great article. It wasn't just about selling their device. It was about keeping these arms healthy. And they were able to come up with the results of 3 mechanical flaws that cause increased stress to the elbow. Arm slot, so where the ball is released, this is the arm slot. Arm speed, so the RPMs. And then that arm rotation, that maximum extra rotation I was referring to. So those 3 combined have found a significant relationship with that elbow varus torque, trying to prevent that valgus stress. The UCL does. There's 1 Newton-meter increase in elbow varus torque was associated with 13 degrees in the arm slot. So if they're a 3/4 thrower, 13 degrees less cause 1 Newton-meter increase in force at the elbow. Okay? The rotation, 116 degrees increase in arm speed. The arm speeds are up about 1,000, and 8-degree increase in arm rotation. So the more external rotation, the more force. This is what the sleeve looks like. It's got a little accelerometer built in. I have an iPad hooked up to it. It gives me instant data, so live on the screen every throw. The example here is a kid is throwing a 3/4. You can see arm slot number is 42 degrees. And what I had him do, I said drop down to a sidearm, and you can see his arm slot went down to 15, and the flag came up, a red flag. So this app gives us live data on how many stressful throws. These 3 numbers combined, what's that number that we're getting that's stressing them? This is a great resource for your patients and your families. It's pitchsmart.org. You can go on here and find all the pitching guidelines. You got those risk factors I showed you. There's a lot more than those at the on this website, and you can find things like the days of rest in between throwing and pitch count. Like this is an example. If you look on the left column, it's an age. So a 11 to 12-year-old who threw 50 pitches in a game should require 2 days of rest. So it's just a lot of information out there that we're not using. So what I'm trying to do is educate these families, the coaches, the parents, and all the providers on we got to use the data that's there so we can help limit these injuries. And as much as I love working with baseball players, I'd rather see them on the field than in the clinic. Thank you for your time.
So basically I'll talk about endovascular cerebrovascular disorders. I know this is something that you guys probably don't see very much of, so I'll try and focus on 3 things that you might actually see. So let's see if this works. I have no disclosures. So this first patient is a 46-year-old healthy woman who suddenly got the worst headache of her life. Showed up in the ER with this headache. She was non-focal but very lethargic. And so the CT scan here shows, let's see if I can make this work. Well, I don't know. Basically the one on the left shows a CT with a classic subarachnoid hemorrhage. And the right is a CT angiogram demonstrating a basilar aneurysm. Let's see if I can make this point. How does a pointer work? Exactly. There we go. So this is the basilar artery, and that right there is a ruptured basilar aneurysm. So now typically with aneurysms that rupture, they bleed and then they stop. If they don't stop bleeding, the people die instantly within a matter of minutes. So about 10% of ruptured aneurysms, the patients die instantly. 90% of them will live long enough to make it to the hospital. But even despite medical treatment, about 50 to 60% will ultimately end up dead or permanently disabled. So this is a 3D span of a cerebral angiogram demonstrating this basilar aneurysm. So here's the vertebral arteries, this is the basilar artery, and there is the aneurysm. So now this is a lateral view demonstrating vertebral basilar, and there's the basilar aneurysm. And then an anterior view, again demonstrating the vertebral arteries, basilar aneurysm. So the way that we tend to treat these nowadays is all endovascularly. So we thread a microcatheter up all the way from the femoral artery all the way up into the head, and we pack it with these little tiny platinum coils, which you see right there, which fill up the aneurysm. The whole aneurysm clots off right away, which prevents more blood from getting into it so it can't rupture again. And then what happens is it turns into just a mass of scar tissue and platinum over time that typically won't ever regrow or rebleed. And this is obviously a much less morbid way of treating patients than doing an open craniotomy. So cerebral aneurysms are generally congenital lesions, meaning the vast majority of people who have them were probably born with them, though they may have started small and they can grow with life. It's actually very, very rare for someone to develop an aneurysm from scratch when they didn't have one. The overall incidence is somewhere between 2 and 5% of the population will actually have an aneurysm. However, if you have one, the rupture rate is actually pretty low. It's typically less than 2% per year overall. Things that increase the risk of rupture are cigarette smoking, hypertension, and drug use, specifically cocaine and methamphetamine. But other things, exercise, head trauma, stress, all the other kinds of things that people worry might make them rupture, do not increase the risk of rupture whatsoever. The risk of rupture is related to the size of the aneurysm. The bigger they get, the more likely they are to rupture. Typically, in an incidentally discovered aneurysm, we don't really worry about them much at all until they start getting to be about 5 or 6 millimeters in size. Any less than that, and the rate of rupture goes way down. Likewise, the older the patient, the lower the risk of rupture. There are some vagaries to this. A very irregularly shaped aneurysm may be more likely to rupture. Certain locations are more likely to rupture. Other locations, there's no chance of rupture. So you get aneurysms in what's called the cavernous segment of the carotid artery behind the eye. There is zero risk of rupture of those, so we don't worry about them. So I end up seeing a lot of incidentally discovered aneurysms, most of which only need to be followed, or some of them are so small they don't even really need to be followed. We find a lot of these incidentally nowadays, typically in older people who come in, either they have a head bump or they have a TIA, they get a CT angio, they find an incidentally discovered aneurysm. The vast majority of those don't ever need to be treated. So generally speaking, we recommend treating unruptured aneurysms greater than 5 to 6 millimeters in size in patients younger than 70. There aren't necessarily hard and fast recommendations in this, but that's the general indication. Ruptured aneurysms, though, are a different deal. So when an aneurysm comes in ruptured, generally speaking, as long as the patient is still alive, you do want to treat them. Treating aneurysms is something which we typically try and do within the first 24 to 48 hours. It doesn't necessarily have to be done immediately, like a stroke, because, like I said, the aneurysm bleeds and then it stops bleeding, and then they come into the hospital. However, there is a high risk of rebleeding over the first 2 weeks. So typically we want to get it treated so it doesn't rebleed, because if it does rebleed and they survive the first bleed, they probably will not survive the second. So that's why we usually treat it within about the first 24 hours. Now here's a fundamentally different kind of presentation of an aneurysm. This is one of the rare aneurysms that presents without rupturing. So this is a 64-year-old woman who presented with a partial sixth nerve palsy on the right and a gradual onset of a headache. So not the spontaneous onset of the worst headache of her life. And otherwise, her exam was completely non-focal. So she underwent an MRI and a CTA, which demonstrated a giant cavernous sinus aneurysm. And then she was treated with embolization with something called a pipeline embolic device, which is, as opposed to those coils, which I showed you before, that you pack inside the aneurysm, this is basically a stent, but an extremely tightly woven stent. It's so tightly woven it can actually, while it's not quite watertight, it can dramatically reduce flow across it. So here is a 3D spin. This is her right carotid. That giant thing right there is the aneurysm. Now, I don't know how many of you remember your neuroanatomy, but these typically, while they don't rupture because they're entirely encased in the cavernous sinus, they get so big they compress the cranial nerves going through the cavernous sinus to the eye and cause gaze difficulties. So this is the pre-op imaging. This is preoperatively an AP, like looking at you from the front carotid. So the right carotid, you can see how much stasis of flow is in this. And this is a view of the same thing looking at them from the side. The interesting thing about these is they get so big, they almost have a sump effect. You can see how there's almost sluggish flow up in her head because so much blood is just getting caught up and pooling in this. Now here is a still image of the pipeline device. So here's a microcatheter I've threaded all the way up into here. And this right here, you can see this stent going through the carotid. Problem with these lesions that makes them difficult to treat is not only is there this giant aneurysm, basically the carotid comes in one side and then it comes out the other. And trying to get a wire from one to the other to put the two together is like finding a needle in a haystack. So you're up there fishing around for ages, trying to get a wire across it and then a microcatheter, and you span the entire thing with this stent, which then diverts flow away. And so this is an angiogram right after deploying this. So all this you see here is stasis in contrast. So already it's blocking flow in here. And then this is a view from the front. You can see all this contrast just pooling in it already, and then the flow going through here. And so these patients, this is just an overnight procedure. They go home the next day. We typically put them on Plavix for 6 months and aspirin. And this is what the angiogram looks like 6 months later, with a completely recanalized carotid compared to what it looked like beforehand. With these devices, not only do they block flow and then the thing thromboses off, but they're so tightly woven, they basically provide a scaffolding for new endothelium to grow on. So basically you grow an entirely new carotid endothelium over this stent. So you've got basically seamless carotid going now from there to there, whereas before you had this giant aneurysm. And then the aneurysm itself, once it thromboses off with these, it will actually shrink and go away completely. So a follow-up MR of these will show the aneurysm is totally gone. So this is a big technological improvement for aneurysms, which historically were sort of a nightmare to deal with, where you would have to do an open craniotomy, you would do a bypass, from the superficial temporal to the MCA, or do a carotid to MCA bypass, and then sacrifice the carotid artery. Big morbid operations, a lot of risk, down to what is essentially day surgery. People go home and they're absolutely fine with minimal recovery. So next, carotid stenosis. This is something which I'm sure some of you guys see. So general indications for treatment are asymptomatic carotid stenoses greater than 70% narrowing we typically treat, and symptomatic greater than 60%. Generally speaking, we're talking about patients less than 80. Over 80, the data to support asymptomatic treatment of asymptomatic carotids is pretty soft. It's pretty rare that we need to treat someone over that age. So they can be treated by either a carotid endarterectomy, open surgical treatment, or now by a carotid angioplasty and stent. So stenting, even though it's now been around for a couple of decades, it is still currently reserved for patients who are considered high surgical risk patients. So the most common indications for that are contralateral occlusion. So one side's tight, the other side is totally occluded. Those are higher risk for open surgery. Recurrent stenosis, so they've already had a carotid endarterectomy, now it's re-narrowed from scar tissue, another great indication for stenting. Radiation-induced stenosis, so people who have had, say, laryngeal cancer, they've had a radical neck dissection and then had radiation therapy to it, those should always be treated with a stent. Surgically inaccessible lesion, meaning it's way up under the jaw, so you just can't get to it, or it's way down low, so you can't really get to it without cracking the chest. You're better off just stenting it. And severe medical comorbidities. There's some other sort of less common indications. So, for example, patients who are going to have a coronary artery bypass and they have a high-grade carotid stenosis, even if it's asymptomatic, those patients have a very high perioperative stroke rate during their CABG. So we'll routinely stent those carotids the day before, and then they'll go ahead and have their CABG. So here's an example of radiation-induced stenosis. So you see this very tight, narrow lesion here that was right in the plane of where this person was radiated. So rather than a plaque, it's all just extremely narrow from scar tissue. And this is after angioplasty and stent. Here's sort of dynamic pictures. So before, so this is the internal carotid and the external carotid and the common, and this is after. So there you can see the outline of the stent right there. And it's now completely reopened. Up here you have a little catheter spasm from what's called the distal protection device. So when we do these, we, again, go in the femoral artery, thread a sheath up to here, put a distal protection device, which looks like a little filter, like a windsock, up past the stenosis to catch any debris, then put up a stent and deploy it, and then an angioplasty, and then you take the filter out. So again, a very quick in and out procedure. These patients are typically placed on Plavix for a month. These stents are non-drug-eluting as opposed to coronary stents, so they don't need 6 to 12 months of Plavix. They're very large, so they don't really need to have drug-eluting stents. Actually, the risk of restenosis from carotid stents is very low. It's probably lower even than it is for carotid endarterectomies. So, and then typically what I will do is follow them with ultrasounds annually for a couple of years afterwards, and then biannually for the rest of their lives, just to make sure they don't develop recurrent stenosis. So acute stroke, This is something where interventional technologies have dramatically changed the management of stroke. So as most of you guys are aware, the first big change in management of acute stroke came when IV TPA therapy was approved. So IV TPA, or the clot-busting medicine, is typically given for patients who have strokes within 3 hours, and now there's what's called the extended window up to 4.5 hours out. So if you're within 4.5 hours out of the onset of your symptoms, you can get intravenous TPA for your stroke. The problem is that, A, a lot of people obviously are not found and got into the hospital within that 4.5 window. The other thing is a lot of people just wake up with a stroke in the morning. You have no idea what the time of onset is. Last but not least, IV TPA does not tend to work for what are called large vessel occlusions. So if you block one of the really big blood vessels in your brain, IV TPA typically cannot reopen that. And then again, even 4.5 hours is a very, very narrow window for someone to get found, to the hospital, diagnosed, and getting treated. So you're weeding a lot of people out. So mechanical thrombectomy for strokes, where you physically go up, again, with a microcatheter, and nowadays we use a device or a category of devices called stent retrievers, which are essentially stents on a wire that go up and deploy into the clot, smush it to the side, immediately restore flow to the head. You leave it deployed for about 5 minutes, and then you literally just pull the whole stent out, and it pulls the clot with it and restores flow in there. So generally speaking, the window for treatment with these is about 8 to 10 hours, but this is very much in evolution. There's a lot of research going on using something called CT perfusion right now, which can tell us how much brain is alive and how much brain is dead in a stroke patient. And what we're finding is that the window can vary enormously in people. Some people come in early and the brain is already infarcted and it's too late to do anything. Other people can come in 24 hours later and still have viable brain, and it's worth going ahead and doing a stroke intervention, and they may get dramatically better. So the window historically has been pushed out to 24 hours for posterior circulation, meaning vertebral-basilar strokes. That part of the brain is both a lot more resistant to ischemia, and also the stakes are so high there. Basically, these people are going to end up dead or locked in with this stroke, so you're better off just being aggressive with them because there's almost no chance of meaningful survival for them. And it can be performed in conjunction with IV TPA. Even if someone comes in within 3 hours and they get IV TPA, they can, if they've got a major vessel infarct, you just rush them straight to the cath lab, even if the IV TPA is still going. And so here's an example of an 80-year-old woman who came in, who was found down at home, unknown how long she was down, was severely lethargic, barely able to be aroused when she was found, deteriorated rapidly, and so on arrival to the hospital was obtunded with some abnormal eye reflexes, but basically it was unresponsive, and was found to have a basilar occlusion. So this is her vertebral artery right here, looking at her from the front, and the basilar, and you see this stump right there. And this is a view of the same thing from the side. So the vertebral artery coming up here and this big stump. So even though we weren't sure what the time of onset was, because of the severity of this, we took her straight to the cath lab and threaded a microcatheter up, deployed the solitaire device, pulled it out, pulled a big chunk of thrombus right out from her vessel, and in one pass got restored flow of everything here. And despite her age, which is definitely on the upper end of people that we typically intervene on, she woke right up afterwards and ended up with just a partial field cut to the left and a little bit of very minimal diplopia, but it was otherwise completely neurologically intact. And she ended up going home after this. So, in conclusion, basically neurointerventional techniques allow treatment of difficult or previously untreatable pathologies with much lower risk and much better outcomes. And this is very much a technology-driven field. It's driven by new devices and things like that, so that as new and better devices come out, the indications of what we can treat grow and get better. And this is going to steadily displace more traditional surgical techniques. The end.
Thank you. I'd like to thank Rebound and Dr. Reigel and Dr. McCarran for asking me to speak. And as he said, I will be speaking on the recommended imaging sequences for osteoporosis, osteoporotic fractures, and neurosurgical emergencies. I will do this utilizing a case-based approach. As an imager, I like images. And so we will show several of those. And one quick word, this is a resource that is available for everybody. It's on the web. The American College of Radiology has established appropriateness criteria. And these are evidence-based guidelines developed on consensus panels for almost any case or situation that you need to image. For example, the musculoskeletal conditions are developed with musculoskeletal radiologists, orthopedists, and rheumatologists. The neurological imaging guidelines are developed with radiologists, neurosurgeons, and neurologists. You can look this up, just go to ACR, Google it, and you can browse the topics to look for any condition that you need. You can also call your radiologist. We're always happy to answer any questions about how to image something. So moving on to osteoporosis, we've got two representative images of studies that we commonly see. We use x-rays to look for fractures, and then we can assess the bone mineral density using DEXA scans. And so we know that osteoporosis is a public health issue, with 50% of women and 20% of men greater than the age of 50 experiencing fractures. Bone strength is comprised of bone mineral density, which we can screen, as well as bone quality, which is only assessed when a fragility fracture occurs, and such fractures increase the future fracture assessment. So there are guidelines established by the WHO that help us measure this. So when we speak about fragility fractures, we're talking about non-spine as well as spine fractures. Those non-spine fractures include your ribs, distal forearm, proximal femur, and the proximal humerus. And this is typically diagnosed on radiographs, and we can do serial radiographs to assess the reduction and healing of such fractures. When you suspect a proximal femoral fracture, MRI is actually more sensitive for finding that fracture. It's preferred over CT, and although CT is increasingly indicated for pelvic fractures due to the complex anatomy. 60% of the vertebral fractures are asymptomatic, and this gives a clue as to why these may occur progressively, and you get a change in the vertebral body configuration over time as fractures progress or you acquire new fractures. So there are several imaging options. The one that we will speak about the most and we most commonly encounter is dual energy X-ray absorptometry. This is a projectional X-ray that assesses the bone mineral density in the lumbar spine, hip, and the distal forearm. There are other imaging options, which we've mentioned radiographs before, and we'll see those in the upcoming slides. Other entities which we don't use as often and are not as common in practice are single X-ray absorptometry, quantitative CT, and trabecular bone score. So our first case is a 76-year-old female, not on hormone therapy, and she has a family history of osteopenia. So you want to screen this lady, and you order a DEXA. And so here we see the right and left femoral necks. This is the preferred site in the femur. Given varying clinical scenarios or situations, you can use different portions of the femur, but the femoral neck is preferred. If there's an arthroplasty in place, you would exclude that femur. So we like to, we like to use, for postmenopausal female, we use the T-score, and for her right hip, it's -1, which is within normal limits. So she has normal bone mineral density in the right hip. You go to the left hip, and her T-score drops to -1.8, which is osteopenic. Next, you assess her lumbar spine, and ideally, you calculate the bone mineral density based on L1 through L4. If there's a compression fracture or instrumentation, you exclude that vertebral body, and as long as you have 2 vertebral bodies to assess, you can still use the lumbar spine. Less than 2, and you have to use a different site. Her T-score here is -0.1, which is normal, but in calculating her overall exam This qualifies an osteopenia because you take the worst possible site, which was that left femur. So, moving on, DEXA can be used to assess asymptomatic patients for screening as well as follow-up. Identify and follow up bone mineral density, particularly in premenopausal females, males between the ages of 20 and 50 with risk factors, and in those patients that are over the age of 50 with advanced degenerative disc disease, whether or not scoliosis is present. These other tests come into play in different factors. So if they have T-scores less than -1, they qualify as normal, but they have one or more risk factors, you can do a vertebral fracture assessment. Qualitative CT can be used in follow-up, as well as in those patients with advanced degenerative disc disease with or without scoliosis. If you have a symptomatic suspected acute fracture and the patient has known osteoporosis or chronic steroid use, you start with radiographs, but if those are negative and you have a high suspicion, you have to go on and do a CT or an MRI because that gives us a better picture. MRI is so sensitive it can pick up bone marrow edema, and you might catch something very early before they progress to fracture. If the patient has long-term history of bisphosphonates and presents with thigh or groin pain, you first get x-rays to look for an atypical femoral fracture, which we'll discuss in a little bit. But if those are negative, again, you get the CT or the MRI and you image bilaterally, so you have an internal comparison as well as to catch an early process on the contralateral side. And one note about history. History is incredibly important for insurance coverage, primarily for your Medicare and Medicare replacement plans. Screening is not covered, and so you have to give an acceptable diagnosis code. And that includes menopausal or postmenopausal status, known vertebral fractures, or on drug therapy, as well as these other entities listed. And so we'll go on to fractures. And typically, these patients present, you get an x-ray, it's positive, it's negative, it's questionable. We have some other options to go on and look at these patients. CT is great because it allows us reformatted images where we can look at sagittal and coronal as well as the axial planes to catch those fractures. And I always utilize those planes, especially in the spine. The sagittal images are extremely helpful because I may miss something on an axial image, but if I go to my sagittal or coronal images, I'm going to see the change. It's that added benefit there. You can do a DEXA in your postmenopausal females over the age of 70 or men over the age of 80, and in patients with height loss and diseases associated with risk of vertebral fractures. MRI is reserved primarily for a problem-solving tool, particularly in the proximal femur. And again, this can assess bone marrow edema. So you may not have a fracture yet, but if there's edema, I alert the clinicians to the fact that there's a stress reaction and we need to think about what we're going to do with this patient next. So we have a 74-year-old female with chronic history of back pain and falls. She's not on hormone replacement. She has a history of osteopenia. She comes in and they get a CT. The initial study shows an L1 vertebral compression fracture. She comes back a few months later, has progressive pain, more falls, and you see that not only does she have the L1 compression fracture, but she also has an interval depression of the superior end plate of L3. This is just an example of this change in vertebral body configuration over time and the fact that they get one and then they're going to be at risk for another. Next, we have an 82-year-old female that comes in with hip pain and, again, has a history of multiple falls. Her first x-ray shows a left intertrochanteric hip fracture. She comes back 1 year later, and we see that she has had her hip fracture fixed, but she has a right hip intertrochanteric fracture. So they go ahead and get a CT, and you can note that she's got decreased mineralization. She has the intertrochanteric hip fractures demonstrated on the axial image here. On the coronal image, you see there's some mild impaction and varus angulation. The follow-up x-ray shows that she now has a matched set. She's had both hips fixed. And so next we have an 86-year-old female that complains of pelvic pain, and she fell a week ago. given the complex anatomy, the first study that they ordered was a CT. You see the sacral fracture here within S2. Utilize your coronal images to look for additional fractures. I always look very carefully here at the sacrum. And then your sagittal image again shows the fracture here. So one word about atypical femoral fractures. This is a rare complication of bisphosphonate use, but we have to remember that for every case of, for one atypical femoral fracture, we prevent 100 hip fractures. These are called short transverse fractures or a chalk stick fracture. The patients present with a prodrome of thigh discomfort. They are spontaneous and atraumatic in onset, and you can look at these with x-rays, or again, if those are negative, go on and get your MRI or your CT. So moving on to neurosurgical emergencies, we have two main imaging studies that are going to be of help, CT and MRI. CT is fast. It's available almost everywhere. It's developed to the point now that we can decrease the radiation dose quite a bit. We can actually modulate the dose per each patient, so we're not over-radiating any more than we have to. It has a low susceptibility to motion and has the multiplanar ability. There are risks of ionizing radiation and contrast exposure, so these patients also require screening for renal dysfunction and contrast allergy. Our imaging options include a CT without contrast. This is really the workhorse. Patient comes in, most of the time they get a non-contrast head CT because it is the first-line imaging modality for intracranial hemorrhage, regardless of the cause. It also identifies calcification. If there is concern for mass, fluid collection, or infection, a CT with intravenous contrast is useful. If you're looking at the vessels, whether they're the arteries or the veins, we do a CT angiogram for the arteries, looking for dissection, stenosis, occlusion, or aneurysms. Venography can be done to look for venous sinus thrombosis or vascular malformations. And then CT perfusion, which we will not discuss, assesses the cerebral vascular reserve in patients with stroke. In regards to MRI, it has great soft tissue resolution, no ionizing radiation, making it ideal for patients of young age and pregnant females. It's also multiplanar. It is a longer study that is more susceptible to motion. Devices that the patient might have implanted have to be documented as safe for MRI, and these patients have to go through screening. There is the issue of gadolinium-based contrast exposure, which has been in the media recently, that we found that gadolinium does get deposited in tissues, particularly in the brain. We don't know the long-term effects here, but you still have to assess the benefit and the risk to the patient. If there are any questions, your radiologist is happy to answer these. MRI may not be as widely available as CT, and there are metal implants that limit the usefulness because they distort the magnetic field, but there is technology that can limit this artifact, and it's a particular use in your patients with spinal hardware or joint replacements. Again, your imaging studies are very similar to CT. You have an MRI without contrast, that's your workhorse. It can assess everything from infarct to mass, to bleeds, to fractures, herniation, edema, or any mass effect or midline shift. Contrast is always added in cases of suspected mass, infection, fluid collections, or if the patient has been through surgery. Again, when you're looking at the vessels, there's MR angiography, which may be performed with or without contrast depending on the scenario, as well as MR venography to look at the veins. And then MR perfusion can also be used to assess the cerebral vascular reserve. So we'll go on to discuss stroke. And here you have your transient ischemic attacks, your acute stroke greater than 6 hours. And those histories are important as we help decide which imaging studies to do. Frequently, again, you're going to get that non-contrast head CT to answer the question of bleed, no bleed. And then in your TIAs, you go through and get the MRI with contrast, and then you can assess the vessels using MR angiography, and there are options to do this without contrast to look at the vessels. Typically in the neck, we do give contrast, but this can be altered for the patient. And then if the patient has an acute stroke and you've ruled out the bleed on the head CT, you then go ahead and order a CT angiogram, where we give contrast, to look for large vessel occlusion to guide future intervention. And then if they're greater than 6 hours, you go with the MRI to date the age of the infarct, and then again your angiograms to look at the brain and neck vessels. So for aneurysms, those patients that have risk factors, you can screen with a time of flight, MR angiogram, or the CTA. And then when you follow up those unruptured aneurysms, you just keep using the same modalities so that we're comparing apples to apples and assessing for that small change in size that might alter the management. In cases of suspected vasculitis, MRI to look at the brain parenchyma as well as the MRA to look at the vessels can be done. If MRI is contraindicated, you can do a CT or a CTA. And then cerebral venous thrombosis, you have options of MRV or CTV. MR you would choose for those young patients or pregnant patients so that you don't radiate them. And then you also get an MRI to look for parenchymal complications such as multiple venous infarcts. So for hemorrhage, if it's non-traumatic, the first study you get, again, is that CT without contrast. And then you get your CTA to look for your vessel abnormality and find the aneurysm. The digital subtraction angiography that Dr. Shano showed is typically when people are actually treating these lesions. In cases of hypertensive hemorrhage, you can follow these patients with CT without contrast. This will show you how the hematoma is evolving and resolving and any complications that occur. For non-hypertensive hemorrhages and you're looking for that underlying source, again, your MRI or your CT with your CTA, MRA, or MRV or CTV to assess the vessels are your imaging options. So we have a 63-year-old male with new onset of vertigo. He gets his CTA. And here you see you have your internal cerebral arteries here, a little more posterior and lateral. You have your jugular veins, and then you have your left vertebral artery here, and you can kind of make out a right vertebral artery here, but there's this hypodense filling defect, which you see on the additional images here. And right here, we don't see a right vertebral artery. Go to your coronal image, left vertebral artery is nice and opacified. Your right vertebral artery is nearly occluded. This is either an occlusion or a dissection. And next, we have a 75-year-old male that comes in with altered mental status. And you see that he has these old infarcts in the parietal lobes. But there's always the concern of peri-infarct ischemia or an acute infarct that we may not pick up on CT. An initial CT very early on may be negative. And so you get an MRI. And these are three of the most important sequences on MRI. First, we have diffusion. This is the first sequence I look at. And here, you want to look for anything that is bright or hyperintense for an acute stroke. This is choroid plexus, and this is edge artifact, so trust me, those are not lesions. Where he had his infarcts on the CT actually are hypointense or slightly dark. So I don't see anything suspicious for acute stroke on diffusion, but I go to my ADC map to confirm it, and anything that is acute should be dark. I don't have anything dark here. In fact, I have bright or hyperintense signal in the parietal lobes. And this is confirmed on T2, which takes longer to show pathology and stroke. But you'll see that it's hyperintense, and this is gliotic tissue from old infarct. This patient did not have an acute infarct on imaging. So next, we have a 60-year-old male with left-sided weakness. His last known normal was 90 minutes prior to presentation. He was fortunate enough to get into the MRI scanner very quickly. And here we have the diffusion image, and that shows hyperintense foci in the right frontal lobe. It's confirmed on the ADC where you see this dark signal here, and this was an acute infarct. So next, a 55-year-old male with a carotid bruit on the left and intermittent TIA symptoms comes in. He gets his angiogram, and here we have the jugular veins, vertebral arteries, right internal carotid artery, no left internal carotid artery. Go to the axial images. There's my right internal carotid artery. I should have a left, and I don't see it. And here at the level of the carotid canal. So he had a long segment occlusion of the left ICA. We have a younger patient next. She's 1 month postpartum and has had persistent headaches. She gets an MRV nogram. And again, this has no radiation. She is younger, has a long life to live, hopefully. And so you try to limit your radiation. If she was pregnant, I would definitely put her in the MR scanner. I would choose that over CT so that I don't radiate her, the fetus. And here you see the sagittal sinus, your transverse and sigmoid sinuses, and the cortical veins. This was negative, but it's one of the imaging options we have. Now, typically, we will give contrast for this. If she was pregnant, we never give gadolinium-based contrast to pregnant women, and we can do it as a time-of-flight study. Next, we have a 66-year-old male that presents with stroke, ataxia, and right arm and leg weakness. Kind of similar story here. We have our MR angiogram with contrast. This is a MIP where you just subtract out the background images and really highlight the vessels. There's a high-grade stenosis of the left internal carotid artery proximally here. Your diffusion image shows your acute infarct in the frontal lobe, confirmed on the T2 image. And then we have a 66-year-old male with altered mental status after a fall, and he's on anticoagulation. So the first thing you get is a CT without contrast. And you notice here that we have this mixed density extraaxial fluid collection along the left cerebral hemisphere causing mild mass effect, but no midline shift really. And that's consistent with your subdural hematoma. Next, we have a younger female that comes in with the worst headache of my life, which when I hear that phrase, I think of an aneurysm. She gets a non-contrast head CT, and you see this hyperdense hemorrhage that courses in the subarachnoid space following the cortical sulci and entering the basilar cisterns here. So next we have to find where the aneurysm is. And given the location of the hemorrhage on the prior images, you think anterior circulation. And here we have a 9mm ruptured aneurysm in the region of the bifurcation of the internal and middle cerebral arteries, as well as the posterior communicating artery here. So for head trauma, patients with acute head injuries, you get that CT head without contrast. If they've had total brain injury and you're following them up, if they're doing okay and not deteriorating, you can get a CT head without contrast. If they're getting worse, you can image with CT head without contrast or MRI. You add contrast to either the CT or the MRI if there is concern for infection. In patients with subacute to chronic TBIs, you start with the MRI without contrast, although if they're rapidly getting worse, get the CT because it's fast. Again, arterial or venous injury, you do the CT or MR angiogram or venogram. And if you're concerned about a post-traumatic leak of CSF, then you start with a CT head without contrast to look for a skull-base fracture. If that's negative, you can do a nuclear medicine cisternogram. And so we have a 76-year-old male with head trauma. And he comes in, and we have a non-contrast head CD that shows a large extraaxial mixed density fluid collection causing mass effect, midline shift of the ventricular system. There's an infarct here. We add contrast to look and see if anything enhances, indicative of infection, which we don't see. And then here's just the utility of the coronal image to show that midline shift, the mass effect. So when we go on to spine trauma, again, we have CT or MRI to use. The CT-based studies are the gold standard for spinal fractures. You don't have to give contrast. We get these in about 30 to 45 seconds. You have your multiplanar images, so you can look at everything in multiple planes. If there is concern for arterial injury, particularly if we find a foraminal fracture, you get a CTA head and neck to look for primarily vertebral injury, but of course we're looking at the carotids as well. If the patient cannot have an MRI, and you need to look at the spinal cord, spinal canal, you can get a CT myelogram. For MRI-based studies, these are what we prefer for soft tissue injury, spinal cord injury, and in terms of the MRA versus CTA, they're equivalent in their utility for looking for vascular injury. And so, kind of a long list of a cheat sheet here, but acute trauma, you get a CT of the spine. And if the patient's getting a chest, abdomen, pelvis, we can actually pull the data from the spine from those images, manipulate the images a bit, and we don't have to rescan the patient. If there's spinal cord or nerve root injury, MRI without contrast. If you have positive x-rays or you're planning treatment and the spine is unstable, CT or MRI without contrast. Arterial injury, again, you're going to use your vascular options of CTA or MRA. If the patient's obtunded and the CT is negative, you do the MRI without contrast. Patients with suspected ligamentous injury, MRI without contrast. And if they've got blunt trauma without unstable injury, but you keep them in the collar, you can follow these patients up with CT or MRI without contrast or x-rays. And then if they've got neuroabnormalities and the x-rays are positive or that non-contrast CT is positive, you take the step further and you get them an MRI. We don't need contrast. So for low back pain, in patients with trauma, osteoporosis, elderly or on steroids, we can image this with x-ray, CT, or MRI, no contrast needed. If you suspect cancer, infection, or immunosuppression, MRI is preferable, and you would do this without and with contrast. If they can't get a CT, if they cannot get an MRI, then a CT will work. Patients with cauda equina or rapidly worsening neurological symptoms, MRI with and without contrast. If they can't get the MRI, CT myelogram is an option. For traumatic myelopathy, these patients get a CT or an MRI without contrast. X-rays are usually done as the initial trauma series work up. If it is painful myelopathy and you suspect infection or cancer, you get an MRI without and with IV contrast. If it's simply spondylolysis you're more concerned about, a CT will suffice. If it's sudden onset of myelopathy or slowly progressive, you would want to get that MRI without and with contrast, and then if there's suspected vascular pathology, add that MRA. So here we have a 69-year-old male with back pain, but no history of trauma. So right away, you see this destructive process here in T6, and to a lesser extent, T5 here. It's involving the posterior element, so you have to really be concerned about what's going on to the spinal cord and the spinal canal. And so this patient gets an MRI with and without intravenous contrast. And here you see this marrow abnormality and deformity. You see this mass extending out of the vertebral body and the left greater than right posterior elements. It's invading the spinal canal. This is your spinal cord and it's being compressed. So you go to your sagittal images, same story, T6, T5, posterior elements. You have this soft tissue mass extending into the spinal canal, and you have this bright signal or hyperintense signal in the spinal cord that's consistent with myelopathic change. So the cord is compressed by this tumor. Then we have a 39-year-old female. She uses drugs, labs are abnormal, and she's febrile. And so in this case, you have a high suspicion of infection. She gets her MRI with and without contrast. Here you have some abnormal signal in C4 through C7. And you have this fluid collection posterior to C6 and C7. You give contrast and it lights up with peripheral enhancement. This is an epidural abscess. These patients are at risk for seeding the rest of their spine. She had some just diffuse pain, and so her lumbar spine got imaged, and you see this fluid collection compressing the right aspect of the thecal sac at the level of the sacrum. Some similar hyper-intense signal here on the left. On the contrast images, you see the enhancing epidural abscess on the right, some phlegmonous change on the left, and the sagittal images just help to confirm your epidural abscess at L5 and S1. That is all I have.